siempre tomamos decisiones. Decisiones que nos acercan al futuro, que nos permiten brindar un mejor con confianza. En Tecnoimagen abrimos las puertas a la innovación, pero con un propósito claro: acercar la tecnología a las personas. Porque cada avance, cada desarrollo, cobra sentido cuando impacta en la vida real de los pacientes. Hoy celebramos 25 años trabajando codo a codo con quienes nos eligen, acompañando a los profesionales de la salud en su crecimiento, compartiendo cada desafío, cada logro. Porque sabemos que la tecnología solo es innovación cuando está al servicio de las personas. Gracias por elegirnos para recorrer este camino juntos. Celebramos
I don't need
25
this
años de
translation, don't
innovación.
worry. Just the question, just the question. No problem, no problem.
En la vida siempre tomamos decisiones. Decisiones que nos acercan al futuro, que nos permiten brindar un mejor cuidado y avanzar con confianza. En Tecnoimagen abrimos las puertas a la innovación, pero con un propósito claro: acercar la tecnología a las personas. Porque cada avance, cada desarrollo, cobra sentido cuando impacta en la vida real de los pacientes. Hoy celebramos 25 años trabajando codo a codo con quienes nos eligen, acompañando a los profesionales de la salud en su crecimiento, compartiendo cada desafío, cada logro. Porque sabemos que la tecnología solo es innovación cuando está al servicio de las personas. Gracias por elegirnos para recorrer este camino juntos. Celebramos 25 años de innovación y compromiso con la salud.
Hola, hola, muy buenos días. Hola Darío, ¿cómo estás?
Hola Cari, hola, buen día a todos.
¿Cómo estás? Bienvenidos a todos aquellos que se están conectando de distintos puntos de Latinoamérica y del mundo. Bienvenidos a esta nueva edición a cursos Manejo Integral del Cáncer de Mama. ¿Cómo estás, Darío? ¿Desde dónde
Bien,
se están
Cari,
conectando?
todo muy bien. Acá ahora vamos a ver, se comparten desde distintas partes del mundo. Realmente muy contentos por nuevamente compartir con ustedes esta mañana de sábado, que va a ser una mañana muy intensa, ¿no? Vamos a tener muchos invitados internacionales, los cuales, gracias a la Fundación Veronesi, a la Universidad Veronesi, van a poder compartir con todos ustedes las últimas novedades en lo que respecta a la patología mamaria.
En la vida siempre tomamos decisiones.
Bueno, si
Decisiones que
podemos
nos
ir sacando por favor el video, así nos permiten ir compartiendo la presentación. Exacto, muchísimas gracias. Podemos ir abriendo el chat, que queremos saber desde dónde se están conectando, de distintos puntos de Latinoamérica. Y ya faltan 2 minutos como para poder ir ya comenzando con este curso internacional que todos los años siempre estamos esperando para enterarnos las novedades. Y bueno, acá nos está saludando la doctora María Doretti, la doctora Laura Wolf, Ernesto Gildesa, la doctora Paula Cifras desde Chile, Laura Wolf desde la ciudad de Bolívar. Qué lindo leerlos. Bienvenidos a toda la comunidad que forman parte de la comunidad latinoamericana de imagenólogos mamarios, porque la doctora Wolf, la doctora Cifras, la doctora Semeniuk, la doctora Casteller,
Ok,
doctora...
sí, la doctora Verastegui. Bueno, ya tenemos, Cari, más de casi ya 200 participantes en línea. Faltan 2 minutitos para que sea las 8 en punto de la mañana.
La,
Realmente les agradecemos a todos. La
La
doctora
doctora
Nubría,
Verónica Baró, desde Ushuaia, que nos está escuchando, desde Valencia, Valenzuela, la doctora Dulce, el doctor Pochettino, Pablo Basualdo, Agustina Graciani, también del Hospital Italiano, pero nos está escuchando desde La Plata, la doctora Sandra Lara, desde Colombia, qué lindo leerlo, Luisa Moral, desde Salta, cariños, la doctora Estela, desde Buenos Aires. Bueno, qué lindo leerlos a todos. Y ya, Darío, siendo en punto, vamos a compartir, ¿te parece la presentación?
me parece bien que compensemos un poquito cómo va a ser el día de hoy y les contemos un poco, como les dijimos, una jornada extensa, pero creo que va a ser apasionante, donde vamos a abarcar todos los distintos temas de la patología mamaria. Así que, Cari, si querés, empezá un poquito a
A
contarnos
presentar.
qué va a pasar hoy.
Bueno, darles un poco las instructivas con respecto a cómo va a ser las presentaciones. La mayoría de las presentaciones son en inglés, por lo tanto, quienes quieran escucharlo en su idioma original, en la parte de abajo del Zoom tiene la que dice interpretación, este globito del mundo, y los que quieren escucharla en su versión original en inglés, pueden elegir en inglés, y los que prefieren escucharlo en español, lo escuchan en español, teniendo la traducción, la interpretación desde el inglés al español. Así pueden apreciar todas las conferencias. Esto lo pueden seleccionar desde la parte de abajo en el Zoom. Con respecto a dónde puedo dejar preguntas, el chat, por una cosa de no interrumpir a los disertantes, se va a apagar cuando los disertantes comiencen a hablar. Por lo tanto, si tienen alguna pregunta, lo pueden hacer en este botón que dice preguntas y respuestas. Y algo muy importante que lo vamos a repetir a lo largo de las conferencias es el certificado. ¿Cuándo le vamos a enviar el certificado? El certificado se enviará dentro de 15 días a su correo, así que esperen a recibirlos. Después de pasado ese tiempo, si no lo recibieron, pueden contactarnos. Darío.
Bueno, los invitamos a todos nuevamente a sumarse a la comunidad latinoamericana de imaginólogos mamarios. Como siempre decimos, abarcan a todos los que se dedican a la patología mamaria. Este es la página de Facebook, también puede estar en CLIM. Bueno, ya en el próximos cursos de la comunidad le vamos a contar muchas novedades que vienen para el año 2026.
¿Qué novedades tenemos? Que el 27 al 29 de marzo del 2026 vamos a tener la modalidad presencial de CLIM Academy, que va a ser en Miami, una capacitación personalizada en imagenología mamaria e intervencionismo. Los directores, el doctor Darío Sheckman y quien les habla, la doctora Karina Pese. Como ha sido la edición 2025, es con cupos limitados, ya que nos permite tener una formación exclusiva y práctica. Los que quieren participar, acá tienen escaneando este código QR la forma de inscribirse, y para más información pueden visitar nuestra página web que es climlatam.org o a nuestro mail que es contacto@climlatam.org. ¿Qué van a
Exactamente,
vivir en el curso, Darío?
los esperamos realmente a todos. El año pasado se quedaron muchos sin poder participar porque las vacantes, como dijo Cari, son limitadas, porque es un curso presencial y vivencial. Vamos a conversar sobre las estrategias prácticas de cómo manejar las imágenes y el manejo de la patología mamaria. Van a haber técnicas de biopsia, van a haber técnicas de localizadas, va a haber mamógrafos, donde van a poder trabajar con los mamógrafos, va a haber ecógrafos, donde van a trabajar con los ecógrafos, va a haber estaciones de trabajo en donde van a poder trabajar con una workstation donde trabajan cotidianamente, van a tener la habilitación de casos complejos, bueno, muchas novedades con respecto también al año anterior. Y la inscripción temprana cierra el 1 de diciembre, son $450, está incluido la cena de bienvenida y todos los materiales del curso. Y a partir del 2 de diciembre al 27 de febrero pasa a 550 y si hay lugar todavía, a partir del 28 de febrero pasa a $650. Así que hoy se lanza. Les decimos, bueno, el que cree, el que puede, gustaría participar, que se anote lo antes posible.
También hay posibilidades para aquellas instituciones en donde participen 4 o más participantes, que se les puede hacer una tarifa o un arancel preferencial que también pueden consultarnos. Los que quieren inscribirse pueden aprovechar escanear el código QR que compartimos aquí en la pantalla. Esto fue lo que se vivió en abril de 2025 en lo que es la sede de Miami de Fujifilm, que es un socio estratégico de CLIM, y son todos los participantes de distintos puntos de Latinoamérica. No se pierdan la posibilidad de participar en el 2026. Y Darío, tenemos el honor de ya tener nuestro primer curso CLIM en Brasil, que va a estar la directora, la doctora María Julia Calas, que es la directora de CLIM Brasil. Acompañando a la doctora Julia Calas va a estar el doctor Darío Scheckman con una conferencia sobre inteligencia artificial en imágenes mamarias. Va a ser el día 12 de septiembre de 8 a 9:15 horas. El aula es online. Y las inscripciones, Darío, creo que son totalmente gratuitas, ¿no? Que nos
Sí,
escriban
eso,
a CLIM en las páginas y le vamos a compartir los links de inscripción.
Cari, esta es solamente la mesa del día 3, pero son 3 días. Las jornadas, 2 días son online, en donde se pueden, el que quiera nos pide, le mandamos la inscripción online, y es un día presencial que es en Brasil, en Río de Janeiro.
Perfecto.
Más información también va a haber en la página de CLIM, y más información también lo pueden encontrar en Instagram. Esto es solamente la mesa redonda en donde vamos a participar, pero las jornadas son muchas más, son 3
Mucho
días
más
completos,
extensa.
mucho más
Exacto.
extensas.
Así que aprovechen a este primer curso CLIM Brasil dirigido por la doctora María Julia Calas. Bueno, y le damos ahora sí la apertura oficial al curso del Instituto Europeo de Oncología, cuyo director es el doctor Paolo Veronesi, que es director de la División de Cirugía Mamaria del Instituto Europeo de Oncología Milán. Los directores son el doctor Gabriel Farante, que es staff de la División de Cirugía Mamaria del Instituto Europeo de Oncología Milán, director de la Academia Umberto Veronesi Milán. El codirector es el doctor Antonio Frazón, que es titular del grupo de mama del Hospital Israelita del Albert Einstein de San Pablo, Brasil. Y el codirector también es el doctor Alberto Rancati de la Universidad de Buenos Aires, Argentina. Los presentadores de estas conferencias somos
La doctora Karina Pese, que es la jefa de sección del diagnóstico mamario del Hospital Italiano de Buenos Aires, Argentina.
y el doctor Darío Scheckman, que es staff del Servicio de Imagenología Mamaria del Hospital Beilinson en Israel. Ellos van a ser los conferencistas que iremos presentando a lo largo del transcurso de la mañana. Y así le damos la bienvenida a la apertura del curso al doctor Gabriel Farante, que es staff de la División de Cirugía Mamaria del Instituto Europeo de Oncología de Milán, director de la Academia Umberto Veronesi de Milán, quien nos dará unas palabras de bienvenida. Gabriel, te escuchamos.
Muy buenos días a todos, y por 6º año consecutivo volvemos a encontrarnos para participar en el curso de Manejo y Controversias sobre el Cáncer de Mama 2025, con la presencia y el aporte de profesionales e instituciones de prestigio internacional en esta área científica, para subrayar conceptos consolidados y presentar nuevas propuestas que ayuden a encontrar soluciones teóricas y prácticas para nuestros pacientes con cáncer de mama. La UVAC Umberto Veronesi Academy, en alianza con la University of California, San Diego, y con el aporte científico de algunos de los principales médicos que forman parte del programa de cenología del Instituto Europeo de Oncología de Milán, Italia, programa dirigido por el profesor Paolo Veronesi, también director de este curso. Como subrayamos cada año, la consistencia de este curso se basa sobre la convergencia de 3 pilares que lo sustentan. En primer lugar, algunas de las principales instituciones líderes en el mundo en cáncer de mama a partir de los centros de cáncer norteamericanos más importantes, como el Memorial Sloan-Kettering Cancer Center de New York y el MD Anderson de Houston en Estados Unidos, sumados a la Mayo Clinic de Rochester, la Georgetown University en Washington, la University of California San Diego y en Europa, representada por el Instituto Europeo de Oncología de Milán, hoy uno de los puntos científicos de referencia a nivel internacional. En segundo lugar, la convergencia de expertos y científicos más destacados en el sector en sus respectivas especialidades, tanto en Estados Unidos como en Europa, con nuestros dos representantes también del IEO de Milán. En tercer lugar, el tratamiento de los temas y conceptos más avanzados relacionados con el cáncer de mama, algunos de los cuales hasta hace muy poco casi inexistentes, como los CERDs de próxima generación en el tratamiento adyuvante, la aplicación de la mamografía con contraste, el manejo quirúrgico específico en pacientes con mutación de BRCA, las novedades en radioterapia y la protonterapia, la evolución en los últimos 10 años de la reconstrucción autóloga mamaria, los resultados a 5 años del MD Anderson en ensayos clínicos para eliminar la cirugía de mama después de la terapia sistémica neoadyuvante, etcétera, etcétera. Para finalizar, no puedo dejar de señalar en este programa anual de excelencia, con el contenido del científico no sería posible sin nuestros colaboradores también de gran preparación y prestigio médico a partir de nuestros directores Antonio Frasoni y Alberto Rancati y nuestro muy querido profesor Román Rostaño, de nuestros coordinadores Karina Pelle y Darío Schegman en este curso, y nuestros colaboradores más cercanos como los doctores Ernesto Gildesa, Vanessa Krakowski, Belén Rodríguez del Busto y Fabricio Brenelli. Todo este contenido científico está apoyado sobre la sólida estructura organizativa y profesional de la Sociedad Tecnoimagen, al servicio de la educación médica continua, con su director Darío Cordenons a la cabeza y sus principales colaboradores para este curso, Alexander Masrián y Ethel Sánchez. Finalmente, por segundo año consecutivo ofrecemos a nuestros participantes la segunda edición del libro Manejo de Cáncer de Mama 2025-27. Se trata de un compendio y una síntesis del voluminoso trabajo que realiza el Instituto Europeo de Oncología en una convergencia multidisciplinaria de todas las especialidades que tratan el cáncer de mama en el IEO. La Humberto Veronesi Academy y todos sus componentes estamos muy orgullosos de seguir la filosofía del profesor Humberto Veronesi, para quien la educación médica continua en el campo del cáncer de mama era la punta de lanza más avanzada en el campo oncológico. Muchas gracias y muy buen curso para todos.
Gracias, Gabriel, gracias por las palabras. Bueno, Cari, creo que ya estamos listos como para comenzar la primera conferencia. Así vamos.
Exactamente, para
los
quienes
horarios.
quieran recibir el libro, por favor pueden escanear si desean el código QR, que también lo vamos a compartir a lo largo de las distintas conferencias. La próxima presentación, Darío.
La próxima presentación, o de la primera que vamos a tener, va a ser CERS de nueva generación en el contexto adyuvante. Va a estar dado por el doctor Giuseppe Curigliano y el moderador va a ser el doctor Ernesto Gildesa. El doctor Giuseppe Curigliano es director de la división de nuevos fármacos, vicedirector científico del Instituto Europeo de Oncología del IEO Milán, Italia. Doctor Giuseppe Curigliano, please, you can start your presentation.
Yes, of course.
Cari, deja de compartir, así el doctor comparte su presentación.
Deje de compartir, Darío.
Ok.
I need to share the screen. You need to give me the opportunity to share.
Yes.
Perfect. Thank you. Thank
You're
you.
welcome.
So good morning, first of all, to everyone. It's really a pleasure to be with you today and to discuss about a little bit of the future of endocrine therapy in HR-positive, HER2-negative disease. I will discuss specifically about next generation CERTs in the adjuvant setting. As you know perfectly, there are many studies ongoing. All these studies are really important because will change the treatment landscape in the early breast cancer setting. Those are my potential disclosures. So let's start to highlight what is the current standard of care. And in order to understand the standard of care, we need to define the concept of risk assessment. Risk assessment is an important point also for surgical decision, for radiation oncology decision, but is also very important in defining the intensity and the duration of adjuvant endocrine therapy. We know perfectly that the majority of breast cancer cases that we face in our clinical practice are HR positive, HER2 negative. And we know that despite we improved a lot treatment outcome, we still have patients at risk of relapse. In order to define the risk of relapse, we have several prognostic features. The first one is the clinical stage, that in my opinion still represent the most important stratification factor for risk. But we have other prognostic factors that can be based on genomic assay or on new technologies like detection of circulating tumor DNA. And we know perfectly that all these features together can better let us understand which is the optimal treatment for that specific patient. A real-world analysis defined finally several features to better define a risk assessment for any early breast cancer. Of course, if we consider the stage, you would agree with me that high risk usually is defined as a patient with a larger tumor, low risk, a patient with a smaller tumor. Nodal status is another prognostic factor, defining N0 as low risk and N1, 2, and 3 as high risk. Grade, Ki67, level of expression of ER and PGR, residual cancer burden if you deliver a neoadjuvant treatment, and of course, genomic signature. So the most important thing is to identify, to have the perception of the risk in order to better start and personalize adjuvant treatment, because the key point is exactly to personalize adjuvant treatment. Recently has been published on the Lancet a meta-analysis of the early breast cancer cooperative groups. The data, if you remember, have been presented almost 7 years ago. And the question was, which is the impact of extended adjuvant endocrine therapy across subgroups of early HR positive, HER2 negative disease? And in the context of this meta-analysis, if you remember, even if you have a low stage, you may still have a late recurrence risk. But the most important feature was the impact of extended adjuvant endocrine therapy in those patients with a high nodal involvement. Don't forget that beyond the stage, it's also important to remember that on the long term, you have a risk of relapse also for PT1AB tumors and for N0 tumors. Of course, the limitation of this meta-analysis is mainly related to the type of treatment that maybe some patients 25 years ago received. You know, 25 years ago, there was no access to aromatase inhibitor. The level or extension of surgery was completely different. So maybe today we have more appropriate treatment in order to say that this eventually high risk of relapse for T1B is lower than we expect. Of course, another important prognostic factor in that analysis was the tumor grade, still confirmed to be a risk factor for relapse, and the Ki67 at the European Institute of Oncology. We use it for many years, Ki67 as a prognostic factor, since, as you know, in Europe for many years there was no access to genomic assays like Oncotype DX or MammaPrint. In a real-world evidence analysis, we have still a risk of relapse, also for the patient population that clinically we don't define high-risk group. If you check on this real-world analysis, patients with stage 1 or stage 2 may have at 10 years a risk of relapse close to 10%. Of course, we don't have details on Ki67 on grade. It's simply a real-world analysis. More focus, of course, in the high-risk group, in which the risk of relapse is more clear. In the decision-making progress, all the clinical practice guidelines, this is the European Society for Medical Oncology guideline, clearly state that if you have a luminal A-like tumor, I mean high ER, high PGR, low grade, low Ki67, low risk according to genomic assay, the only treatment you should propose is endocrine therapy. This can be aromatase inhibitors, or in a subgroup of patients in which the risk perception is very low and the risk assessment is very low, still we can use also tamoxifen. And the treatment duration should be for a minimum of 5 years. Actually, you know that there are some studies in Europe in which we are trying to de-escalate also the duration of adjuvant endocrine therapy, and we are focusing specifically also in a shorter duration and for the patient population that we really define very low risk. Then we have patients at intermediate or high risk. In this case, the most important discussion is the addition of chemotherapy in this patient population. That is very clear for postmenopausal women according to the Eric Sponder study, not positive, or the Taylor-Exit, not negative. Still, we have an open question for premenopausal women, despite there is a marginal benefit of chemotherapy in this patient population. But endocrine treatment should include usually an aromatase inhibitor, with all the burden of the side effects that can be related mainly in the premenopausal women. And as you know, we have 2 agents approved that are abemaciclib for 2 years and ribociclib for 3 years. So what is going to change for the future? This is really important as a focus. The 2 studies that completely changed the treatment landscape are the Monarchy and the Natalie. The Monarchy was a prospective randomized trial comparing in patients high risk defined as larger tumor with nodal involvement, because in the Monarchy all patients are not positive. They received 2 years of abema plus endocrine therapy followed by standard endocrine therapy versus the standard of care, that is endocrine therapy alone. And the primary endpoint was invasive disease-free survival. If you remember in this study, with the follow-up that up to now is more than 5 years, there was an improvement in invasive disease-free survival with a risk reduction close to 35%. The absolute difference between abema arm and endocrine therapy alone was around 7.6. As you know, at ESMO meeting this year in Berlin, we will have for the first time data of overall survival on the Monarchy. And as anticipated by a press release, it seems that abemaciclib can also improve overall survival in this high-risk HR-positive, HER2-negative population. The benefit was across all the subgroups of the Monarchy, And of course, the cost for patients is diarrhea, that is the most common side effect, and hematological toxicity. The second study was the NATALEE. The NATALEE was a study evaluating ribociclib, another CDK4/6 inhibitor, with the lower dose, 400 milligram, 3 weeks on, 1 week off, for a period of 3 years. And in the NATALEE trial, we don't have only high-risk population. We have also stage 2 patients. So patients with node-negative disease. And the primary endpoint was invasive disease-free survival. Which is the difference between the NATALEE and the monarchy? You can check here that in the NATALEE there were patients T1 and 1, but also T2 and 0, not represented in the monarchy. And then we have a cluster of patients with node-negative disease that were not eligible to the monarchy. So practically the NATALEE trial expanded the use of adyuvant CDK4/6 inhibitors in a patient population that is completely different from the monarchy, with not a long-term follow-up, it's only 4 years. We will see some new data now during ESMO, but in any case, also in this case, a risk reduction. The cost, again, is toxicity. Toxicity that can be liver toxicity and hematological toxicity. Let's go now to the future. What is going on in the treatment of adjuvant HR-positive, HER2-negative disease? Actually, the standard of care is endocrine therapy for 5 years, plus or minus CDK4/6 inhibitors, followed by an extended adjuvant endocrine therapy that actually still can give a benefit to the high-risk population. And so we have 2 types of approach in order to develop the new oral SERDs. The first one is to incorporate oral SERDs frontline together with the CDK4/6 inhibitors. The second strategy is to switch. So you give first the standard of care with endocrine therapy plus CDK4/6 inhibitors, and then you switch to the oral SERDs. And I would like to present to you some of the studies that are ongoing, because it's really important to understand what is going to happen in 2-3 years from now. The first study is the lidERA trial. This is an upfront strategy. Patients eligible are intermediate risk or high risk. So here we are discussing about patients or with an N0, but a G3 and a large tumor, or not positive, or patients with a genomic assay very high, so oncotype DX high risk or mamma print high risk. Patients, actually the study is ongoing and completed the accrual, have been randomized to giredestrant for 5 years versus standard of care. And the primary endpoint is invasive disease-free survival. Secondary endpoint is overall survival. This is a large study, 4,200 patients. The second study is the CAMBRIA-2. The CAMBRIA-2 completed already the accrual. This is another study with an upfront strategy. So we have in arm A, standard of care plus or minus abemaciclib. In arm B, we have camizestrant plus abemaciclib. The most important thing you can check here that the study usually has a duration in terms of treatment of 7 years. 7 years of endocrine therapy with camizestrant versus standard of care, because patients eligible are intermediate and high. The primary endpoint was invasive breast cancer-free survival. So this is a new type of endpoint. It's not only invasive disease that is a secondary endpoint, but invasive breast cancer-free survival. The CAMBRIA-1 is another completely different study. This is a study in which you have a switch strategy. So what does it mean, a switch? You will give finally the standard of care first. It means chemotherapy and then CDK4/6 inhibitors plus endocrine therapy. And then after 2 or 3 years of CDK4/6 inhibitors, there is a switch to arm A, that is a standard endocrine therapy, and arm B, that is camizestrant. The switch strategy is nothing new. If you remember, the big 198 was a study in which there was the switch. So we had 4 arms in the big 198, 2 comparing TAM versus AI, and then there was a TAM followed by AI, or AI followed by TAM. The original idea beyond the switch concept was that eventually, if you switch type of endocrine agent, you can delay resistance. So this was the concept of big 198. The other study is the EMBER-4, another switch strategy. Here we have patients with high risk, only high risk, 8,000 patients in this study. They receive the standard of care, and after 2 or 3 years, they are randomized to imlunestrant versus the same endocrine therapy with the primary endpoint that was exactly invasive disease-free survival. Finally, we have another oral SERD. Actually, this is the only one approved in clinical practice in the metastatic setting only, but we have also studies with elacestrant. Of course, elacestrant is an oral SERD that has the capability to target selectively ESR1 mutation, but don't forget that elacestrant may work also in patients without ESR1 mutation. And specifically, some data from the neoadjuvant or window of opportunity study clearly demonstrate that elacestrant can induce a cell cycle arrest with a substantial reduction of the Ki67. These are studies very similar to the ones we did with AI in the past. And we have 2 studies here. One is the ELEGANT. This was a study that we designed finally starting from the concept of big 198. This was the first study to be designed in the adjuvant setting as a switch strategy. The idea is to deliver 2 or 3 years of standard of care and then to switch to elacestrant versus the same endocrine therapy. I would like to remind to you that tolerability of an oral SERD is much more better than tolerability of an AI. So this will be important also for the quality of life of our breast cancer patients in the adjuvant setting. So this is a table finally summarizing all the studies that I presented to you, studies with upfront strategy, lidERA and Cambria-2, and strategies with switch strategy, ELEGANT, EMBER-4, and Cambria-1. Finally, I would like just to mention another concept. When I introduced the concept of risk, I discussed about circulating tumor DNA, and now we are starting in my institution at the European Institute of Oncology with a large master protocol in which we are going to check patients with several diseases, but specifically also patients with HR positive, high risk, early breast cancer for the detection of circulating tumor DNA. So the idea is exactly to test for ctDNA after surgery to identify all those patients with circulating tumor DNA positive. According to the monarchy, they were something like 10%, but with new generation technologies, I believe Dr. Razzavi will mention for sure this, we have a capability of detection of ctDNA that is higher respect to the first generation technologies. So why is important? Because you can use a circulating tumor DNA first as a surrogate and the prognostic marker, and secondly to check the capability of specific agents to induce clearance of circulating tumor DNA. So it's like assessing in vivo a response before the disease is radiologically evident. I really believe ctDNA will transform the treatment landscape already did in the metastatic setting, but I really believe this can be important also in the early cancer setting and also in the prevention setting. These are the data of the monarchy. Just to remind to you, patients who remained or became ctDNA positive during treatment experienced rapidly a recurrence. And just to remind to you, those patients with a clearance that became from positive to negative had a better outcome with respect to those who were persistently positive. So if you induce clearance, you can impact on the outcome. This is the main message. We need to demonstrate this in a prospective study, of course, and the study is the following. This is an academic trial. It has been designed in the context of the EORTC, pure academic trial in which we are going to check ctDNA with a tailored ctDNA signature that is Signatera. And we are going to do this every 6 months. And once ctDNA is positive, only the positive will be randomized to elacestrant versus the same endocrine therapy. And the primary endpoint is distant metastasis-free survival. And this is a very important endpoint because this is a study that will really assess the clinical utility and the clinical validity of circulating tumor DNA in the adjuvant setting. So in conclusion, I would like to remember that risk assessment still is very important when you are going to treat a patient because you need a personalized treatment approach. And this now is based on stage, and some traditional prognostic factors maybe in the future can be based on new technologies like the liquid biopsy, and potentially you may avoid a lot of unnecessary treatment and unnecessary toxicity. High-risk patients still today maintain a risk of relapse and escalation of treatment with adjuvant endocrine therapy of longer duration and intensification with CDK4/6 inhibitors demonstrated to improve both invasive disease-free survival and, as I anticipated, those overall survival, because in Berlin at ESMO this year, you will see the overall survival data of Abema in the adjuvant setting. And in the future, I believe integrating oral SERS in the standard of care will guarantee a better tailoring of personalized approach, but will also guarantee a better approach for those patients that are biologically at high risk based on circulating tumor DNA. So thank you very much, and I will be very happy to take questions.
Muchísimas gracias, doctor Curigliano, por su excelente presentación y por la síntesis que nos ha dicho de hacia dónde va el futuro. Pero quería preguntarle sobre el presente, porque este año Tannock y colaboradores sacaron un artículo sobre la precaución con la incorporación de los anti-CDK en adyuvancia y quería escuchar sus comentarios, porque ellos plantean que 2 ensayos con palbociclib fueron negativos y plantean que en el Monarch E y en el Natalie hay un problema importante con el informative censoring, ya que hay casi 900 pacientes que no han sido testeados adecuadamente para la sobrevida. Y el segundo punto que me parece muy importante es lo que usted plantea sobre la tolerancia de los nuevos SERP, porque en ambos estudios hay casi un 20% de pacientes que abandonan el tratamiento. Y quería escuchar sus comentarios sobre esto.
Of course, any treatment can give side effects. Also, if you use the CMF and you check the data of Bonadonna, risk mortality for CMF from prospective randomized studies around 5 to 6%. I completely agree with you on the concept that these new agents, CDK4/6 inhibitors, can give toxicity to patients. I treat patients. I am not a theoretical doctor, so I know perfectly does it mean managing diarrhea, fatigue, neutropenia, all the stress of any single patient. Regarding the editorial of Ian Tannock, you discussed about that, specifically published on JCO. I am a little bit surprised that the official journal of ASCO that support the use of CDK4/6 inhibitors in the adjuvant setting then publish an editorial in which the author claims that we should not use the CDK4/6 in the adjuvant setting. So to be a little bit critical, because I know very well Ian Tannock, I am a friend, I agree that in many clinical trials you have censoring. You have censoring also in the CMF trial, if you would like to discuss about this. Censoring is required in order to perform a better statistical analysis. What is really important is not the censoring, but the capability of the investigator to censor those data in which really you will not affect the results of the study. But don't forget that today we have real-world analysis. So if you invent the data in a clinical trials and you don't confirm the data in the real world, of course, that drug is not a good drug. Personally, I believe any one of us, as a medical oncologist, as a surgeon, knows perfectly what should do for her patient or his patient. And any decision I take is every time based on the quality of data I evaluate and the impact that that specific treatment can give on that specific patient. Because when I choose a treatment, I consider comorbidities, age, and also patient preference. Because I have many patients that usually deny the opportunity to receive an adjuvant CDK4/6 inhibitors because you tell them that there is not an overall survival benefit. Now let we see the data of monarchy. I would like to see the magnitude of clinical benefit. And once we see this data, we will decide when and who are the patient to propose an adjuvant CDK. But you raised a very good point. Good.
Muchísimas gracias, doctor.
Thank you, Giuseppe. Thank you very much for your excellent lecture. Thank you. Gracias, Ernesto, por compartir con nosotros esta mañana. Cari, si te parece, continuamos con el programa.
Por supuesto, Darío, excelente presentación. Muchísimas gracias, doctores. Y vamos a continuar con la próxima conferencia, que es ¿qué hay de nuevo en la radioterapia del cáncer de mama? El director científico del Instituto Europeo de Oncología, el doctor Roberto Orecchia, será quien dará la disertación y la moderadora será la doctora Vanessa Krakowski. Dejo de compartir para dar paso al profesor Orecchia.
Hi, good morning. Thank you very much. Do you see the presentation, the slides?
No, the slides, no, doctor.
No? Why?
No, you need to share your presentation. We hear you and we see you, but we don't see the slides.
It's strange because I share.
Mientras el doctor hace y comparte la presentación, les recuerdo a todos que los certificados van a estar dentro de 15 días. Van a ser enviados a sus correos electrónicos.
Now, do you see?
No.
Oh, problems.
¿Podemos ayudarlo a ver para que comparta?
La presentación.
Now.
Ahí estamos viendo.
Now, yes, we see your computer.
I don't know what is happening.
Yeah.
Estamos viendo toda su pantalla, doctor.
Was working, so.
I think that now you need to choose your presentation and it will work. It's not me that you enter to Zoom. You need to enter to your
I
presentation.
didn't try, so I don't know why. So before it was working.
I think that now you only need to compart your presentation.
Sí, doctor, le voy a dejar de compartir la pantalla para que la pueda buscar y abrir y cuando esté disponible
I don't
vuelve a
know.
compartirla.
I apologize for this, but I don't understand why. Techno imaging, okay. Now it's okay?
Yes, now it's okay.
Okay, sorry, but
No, it's okay.
problem of technology. So okay, good morning again. I try to recover 2 minutes lost for this inconvenience. This is the index of the presentation. I will start just with a sort of overview about the general role of radiotherapy in cancer therapy with respect to the very high number of patients with cancer. Estimation in 2022, 20 million, of which 2.3 million of breast, and means that more than 10 million of people need to be treated by radiation. The expected data in 2050 is very impressive, more than 33 million, with an increase of more than 1 million in breast cancer, and this absolutely means that prevention and primary prevention in first is not an option worldwide. Radiation therapy is quite cost effective. The contribution to the cure of the patient up to 40% of the patient, and also very cheap because the impact in economical terms of the general cost of radiotherapy is less than 1% of the total health care budget. In spite of this very good result and very established rule, the perception of radiation therapy and new drug is absolutely disconnected between what is a reality and the common fears. And because probably most of the people are waiting for the magic pills. So I am one of these, of course. But anyway, we have not to forget what is some misconception about the radiation effect. And this has been overcome, especially according to the new, more target therapy, new technique, including proton therapy. One of the questions is probably related to the market. So I believe that it's important also to introduce, in addition to clinical issues, also some economical issues. You can see here the market of radiotherapy. In this year, 2025, about 8 billion of US dollars. Market on pharma, 246 billion, so means 30 times more. What is expected in 2034? About 13 million for radiotherapy, 550 billion for US dollars for pharma. So it means that, of course, this is a problem of lack of investment in radiation therapy research, in radiation therapy study, and so on. In breast cancer, radiotherapy has a long history. I will try in the next few minutes to give you some message about some points that are containing news. And what is also to say is that it is really important also an action in order to increase and improve the capability of radiation therapy to produce new data, new machine, and new contribution to the for solving the problem of cancer care. And just to point out that there are two initiatives, one of the European Society of Radiation Oncology, that is sort of manifesto in order to introduce some action and new key pillars for improving the role of radiation therapy in the frame of the multidisciplinary approach for cancer care. And the other one by ASTRO, with also in the next ASTRO meeting in fall, there will be the new research agenda and some point to be developed in some specialized areas. Some news about the immediate impact on clinical practice. The first one is related to dose and fractionation. We started for a long time with standard. Now is moderate hypofractionation the most employed type of schedule for radiation therapy, and next future will be current and next future will be ultra hypofractionation. A question mark for the future, because probably we have to decrease again the number of fraction, and the single dose is surely one of the most attractive possibility for the next year. Today, the current recommendation by the American and European Society is that the moderate hypofractionation can be applied practically in all the situation. 3 weeks treatment, usually 40 gray in 15 fraction is the current standard of care for most of breast cancer. There are some more caution about the ultra hypofractionation, with the exception of United Kingdom, where it's becoming a standard. And maybe that there is a still lack of mature randomized trial that we have to wait probably some years in order to accept this type as a new parallel standard together with moderate hypofractionation. Surely what we can do is to push in research. We have many trials. They are not so, as I said, mature, and there are also ongoing trials. So there is a lot of interest in pushing on ultra hypofractionation. That means to have a reduced total dose, usually in the frame of 25, 26 gray, in a week 5 fractions. Just to give you a new is the recent ASTRO meeting, annual ASTRO meeting in 2025, few months ago, which presented the long-term result, 10-year result of the Fast Forward study from UK, and in which has been shown that late incidence of local control and incidence of light effect is absolutely the equal, applying 26 gray in 5 fraction with respect to 40 gray in 50 fraction. That means that after this mature result, we can consider appropriate in standard of care this type of fractionation, both for whole breast irradiation, for chest wall irradiation, and also for PBI irradiation. In terms of consolidated push again, sort of reinforce the use of moderated hypofractionation also for regional node irradiation. Again, in ASTRO meeting has been presented the result with a median follow-up of 4 years. A Danish study, the Skagen trial 1, in which the rate of lymphedema was absolutely similar to conventional fractionation with respect to the moderate hypofractionation. Another topic of big interest is the de-escalation of the dose. One of the most consolidated way to de-escalate is de-escalate the volume. PBI, partial breast irradiation, that usually is limited to selected patient. And the new is that very recently, again, not yet published, but presented in the ESTRO meeting, the new guideline by the group, European group of the JEC-ESTRO. All histology are allowed, and the good candidate for partial breast irradiation are younger with respect to the past, from 50 to 40 years, always unicentric, unifocal disease. Insight to disease is accepted. Tumor size up to 3 centimeters. Negative axilla or the presence of micrometastatic disease, absence of lymphovascular invasion, extensive intraductal component, and of course, free margin. Absolute contraindication to PBI are mutation of BRCA 1 and 2, a triple negative tumor. Again, very recently, this year, on Lancet Oncology has been published the result, again, 10 years result, long-term result of UK import law that extend the indication of partial breast irradiation also in patient with involvement of the axilla in 0 and 1, up to 3 positive lymph nodes. And what is the author stated that the 10-year outcome data from the import law support the ongoing use of PBI MRT in patients with lower risk early breast cancer as a standard of care in the UK and internationally. There are other situations in which there are some evidence not fully mature, maybe in HER2 positive breast cancer, in which it is important to consider the value, the added value of HER2 target therapy, also in local control, local regional control. An issue is triple negative, in which radiation therapy seems not to be able to increase or to maintain the local control. Again, the problem of positive axilla from 1 to 3 lymph node, and also the decrease, the escalation in case of patient who receive neoadjuvant chemotherapy. We have not the time to discuss all this data, but just to give you some message. Full omission of radiation therapy has been already studied in some clinical trial, CALG 9343 and PRIME 2. But one of the most interesting things is to use, in order to assess and to identify this type of patient, to use of biosignature. This is just the earlier study with the use of different type of biomarkers, and the luminal trial, the first report of the trial, the luminal trial, show a very similar local recurrence rate if the patient very early, G1, G2 patient, T1 with luminal A tumor with cutoff of the proliferative index of 13.2025. Biomarkers, as I said, are important, really, not only for prognosis, that is very useful to identify patients with low or high risk, and this means the possibility to individualize radiation therapy de-escalation or intensification. I just to remind that the majority, the great majority, are involving de-escalation, and there are very few studies for intensification of radiation therapy. More interesting may be predictive biomarker in order to select the patient that can be really a benefit from radiation therapy. Just a warning, a recent warning, because for example, I already mentioned the Lumina study that suggested the omission of radiation therapy in patients with luminal A. a subsequent analysis on the cutoff of Ka67 showed an optimal sensitivity and specificity of this cutoff. And in this trial, has been observed 25%, 1 of 4, with false positive or false negative cutoff. So means that some warning are needed in order to consider that only one criterion can be enough in order to decide if omit or not radiation therapy. We have a list of specific genomic classifiers for radiation. There is one is new, the Nova Gray, that is a new assay that predicts the individual sensitivity of normal tissue for estimating DNA repair capacity. And this is could be very useful, and very useful in order to assess tolerance of some patient to radiation therapy. This is the list of trial in terms of invasive trial or ductal carcinoma in situ that are ongoing. Of course, we have to wait the result of this trial. One of the most interesting thing for the future is new possible prognostic biomarkers that are the tumor infiltrating lymphocyte, the TILs, and TILs show some interesting effect. For example, in invasive cancer, a low level of TILs is a benefit for local control. High TILs is benefit for triple negative and HER2. Low TILs is a benefit in overall survival, in this case for luminal eye, and it means that patient can be probably stratified also according to these new biomarkers, and also to consider especially the combination of TILs with, as example, the single dose radiation as shown in the ablative trial recently published. 2 words about artificial intelligence. Artificial intelligence is entered in radiation therapy with different steps of radiation therapy. Potentially, the involvement of artificial intelligence may happen in almost all the steps of the radiation therapy workload and planning, but the challenging has to reducing things, reduce the time consuming, avoid operator dependency, and of course to increase the learning curve. The goal are accuracy, robustness, speed, repetitive task and help, and decision-making process. Despite all this possible advancement, today in clinical practice, the use of artificial intelligence is limited to the contouring of organ at risk, to the delineation of target volume, and also in the use on checking the online checking of adaptive treatment. That means that there is a lot of room, a lot of space to increase the more sophisticated technique of artificial intelligence. Quite interesting is this paper recently published on the breast by the Tall Books Consortium. I just point out this sentence that all automatic delineation systems require review and revision by an expert before being used for therapy planning. The other point is this, the initiative, such application of the GARD. GARD is a genomic assessed radiation therapy dose. That means according to the sensitivity of different tissue to radiation therapy to predict tumor control probability and normal tissue complication rate on individual patients should be actively supported by grant agency and research community for enabling the future personalization of radiation therapy. This is a strong topic for to be placed in any program of research to transform the physical dose in a biological dose according to the dose that the tissue received. Another problem in which artificial intelligence may be useful is the optimization of the efficiency of radiation. You can see a lot of steps that involve a different professional profile. And of course, the message is that radiation therapy has to be more green, so shorter treatment, shorter travel for the patient, a better integration with drugs and surgery and other procedures. So the impact, the sustainability of radiation therapy is really to be reached. I just to close my talk with the interaction with a topic that is very interesting today, because what Professor Curigliano said before, the possibility to combine and to change the role of drug and the interaction is really important from the point of view of effectiveness, but also from the point of view of safety. Every day we have a new drug, every day we have the problem how to integrate and to assess the interaction and safety of the combined radiation therapy with target therapy and immunotherapy. We have to study and to know exactly what is the biological effect of radiotherapy that is strongly time depending. So means that the timing of this integration association is very important to get the best effect. And of course, we have also to consider that overlap of possible toxicity according to the different drug mechanism. Another issue that is fastly growing is the use of theranostic and the possibility for radioligand nuclear medicine, but is jointly with radiation therapy in many countries, the possibility to have also in breast, several studies are already ongoing in the use of radioligand. Today are limited to the setting of metastatic disease, probably can be anticipated earlier. And this is another real, very interesting topic to be studied. Conclusion is that we have to move to the screen and characterize approach. Screen and characterize means to identify patients with hard to treat breast cancer at an early stage over the disease course. The screen step is to the availability for all the patients of genomic test, digital pathology, and circulating biomarker. And of course, from the other side, the characterize step is to use modeling biology, NSG, Wool exome, etc., modeling mechanism of action, predicting outcome. The final goal is to move from precision radiation therapy to a real high definition radiation therapy. Thank you very much.
Doctora Vanessa Krakowski.
Buen día.
Buen día, Vanessa.
Buongiorno, Roberto. Come stai?
Buongiorno.
Okay, excellent presentation. Can you hear me?
Too fast.
That was fast. Yeah, like fractionation. So speaking about fast, ultra hypofractionation is establishing itself as a new standard. Considering logistics, do you think in the next 5 years it's gonna become the new standard, the 5-day treatment? And I mean, will it be clinical evidence that will make it happen? Healthcare system pressure on costs or patient preference?
I believe maybe a mix of all of these points. Surely we have to wait before the definitive accept of ultra hypofractionation in a standard of care. Of course, we have to use a more sophisticated technique because require at least EMRT, tomotherapy, etc., stereotactic irradiation, volumetric arc. So means that in breast we have to apply the best standard for all for between all the possibility of radiotherapy, also proton therapy, why not? But future. The second point is sustainability of the system. There is, especially in low and medium income country, a very difficult situation in order to access to radiation therapy, and this type of shorter fractionation can help the capacity of the system or the current number of machines to accept more patients. And this is maybe a general advantage. I mentioned it before, the need for green radiotherapy. Green radiotherapy means to avoid not useful travel for the patient, for the personnel, not so we have to try to optimize, and today it's possible. It's possible because we have new tools, we have new technique, but also we have new knowledge about also the mechanism of radiation therapy. And I'm quite confident that in the next 5-10 years, a new scenario in radiotherapy can appear.
Sure, and we're also waiting for the Europa trial, and hopefully we will do better than oncologists with the 5 days versus 5 years. Just kidding. So,
Vanessa, we don't have so much time. Sorry about that. Only one question because we need to continue with the program.
Perfect.
Yes.
So,
thank you. Bye-bye.
Thank you very much
seeing you all
for sharing
again.
with us. Thank you, Vanessa. I'm sorry about that, but we need to continue. It's a very long program today. Karina, si querés compartir y vamos.
Hello. Yes.
Estoy compartiendo, Darío.
Ahí la veo, perdón.
Excellent.
Bueno, ahora continuamos con manejo quirúrgico de pacientes con cáncer de mama, portadores de mutaciones BRCA. El doctor Virgilio Sacchini va a ser el doctor que nos da la conferencia, cirujano del Departamento de Oncología Quirúrgica Mamaria del Memorial Sloan-Kettering Center de Estados Unidos, Nueva York. Y el moderador va a ser el doctor Javier Soteldo.
Thank you so much. I don't know if you can hear me. Not sure that you can see me, but I don't know if you can see my presentation.
No, we don't see your presentation. We doesn't see your presentation, and we doesn't see you. We don't see you.
Let me.
Can you see? Yes.
Perfect.
Yes,
you can see my presentation. Perfect.
Yes.
I'm sorry that you cannot see me, but it's fine. It's a special pleasure, special honor for me to be here to speak about this still controversial issue on the management of breast cancer in patients with mutation. And the genetic test is becoming more and more frequent now. Can you see my presentation?
Yes, we see your.
Perfect. And because
we see you too.
I cannot. Perfect. Excellent. But unfortunately, I don't know why I cannot see my presentation. But and the genetic test is becoming more and more frequent now, not only in breast cancer but in other cancers like prostate cancer, and gastric cancer, colorectal cancer. So there is a trend in doing more and more the genetic test in all the cancer, of course, especially in ovarian cancer, breast cancer. And I don't know if you can see the progression of my slides.
Yes, but if you want to open the presentation, it will be.
I know, but I don't know why it's not
Virgilio, put it in. Yeah, there you go.
This is now.
Perfect. Excellent. Excellent. Thank you. Perfect. So there was around the years a sort of increase in testing, an increase in the criteria, because we test and now we test more than 50. Before it was more than 60, less than 60. Triple negative cancer, of course, patients with several relatives with breast cancer. But now the trend is to test everyone with breast cancer, especially after the recommendation of the American Society of Breast Surgeons, stating that everyone, all the women with breast cancer should be tested. And the main reason is about the possible involvement for the surgery, prophylactic oophorectomy, also different treatment, PARPs inhibitors, now in high-risk patients, BRCA mutated, family benefit, important to know if in the family there is this mutation to protect other people. So the trend is to test almost everyone. And here in the States, you can see, especially in small hospitals in the community, that everyone is tested. No doubts that without cancer, prophylactic surgery in BRCA1, BRCA2 is considered the standard around the world. We did the study looking at different recommendations around the world regarding the prophylactic surgery, and BRCA1 and BRCA2 is almost accepted for prophylactic surgery. For the medium low penetrance mutations is still controversial, with more an aggressive trend in the United States than in other parts of the world. But the real question now is, when a BRCA patient has breast cancer, do we need to do the prophylactic surgery? Do we need to do the bilateral mastectomy? Do we need to do the risk reduction, oophorectomy? And there were some interesting studies in the last 5-6 years showing that it was possible to save the breast, avoid the contralateral prophylactic mastectomy, a little increased risk of a contralateral cancer, of course, but no difference in the overall survival in these patients. But unfortunately, the follow-up wasn't so long, 10-14 years. Another interesting study, meta-analysis with all the conservation patients with BRCA mutation, showing little increased risk of local recurrences, little increased risk of contralateral breast cancer, but without impacting the survival. Again, not long follow-up, 10 years follow-up. The study, a little of concern, was a study done in 2014 in which after 14-15 years, there was a difference in the overall survival in patients having conservation or not having contralateral prophylactic surgery. In this study, the criticism was the confounding variable of oophorectomy. This is the distribution of the contralateral breast cancers in the years. And you can see that in the first 10 years, the risk is not so high, but after 10 years, there is really an increased risk of contralateral breast cancer in women without the contralateral prophylactic surgery. But this year was the year of the clarification on this point. In Lancet Oncology, there was a very interesting publication on 109 centers in 5 continents comparing a study comparing the patients who had contralateral prophylactic surgery, bilateral mastectomy versus no contralateral prophylactic surgery and conservation surgery. The study was based in Italy, in Genova, and again, multicentric. This is the population. The population is very peculiar because it's a young population, less than 40, but is usually the population that we are now finding in patients with the BRCA mutation. Cancer is usually occurring in the young age, and you can see the distribution of BRCA1, BRCA2. Some patients were tested at the beginning, some other after, and the patients who had the contralateral prophylactic surgery tested after were about 70%, less than 70%, but the prophylactic surgery was done in the first 3 years and 5 months after the first surgery. Interesting is that the distribution of the cancers, T1, T2, but also T3, not early stage, but some advanced stage, and 2 and 3 in about 10% of the patients. The analysis after 20 years is very interesting because you can have an improvement of the overall survival, disease-free survival, breast cancer specific survival, and of course breast event with the prophylactic surgery. So the bilateral mastectomy can increase the survival of these patients, these young patients who had bilateral. If we would like to be more granular in looking at the data, you can see that the years that these patients gain is not so incredible. Is 1.2 overall survival years, 4 years of disease-free survival. But the problem is also quality of life. What happened when the patient was diagnosed with a new cancer, often triple negative in BRCA1 mutations, and all the possible treatments. Sometimes another chemotherapy after the second cancer. So also quality of life is important in this situation, and unfortunately not reported in the study. Also important, of course, the risk reduction, salpingo oophorectomy, and again an improvement in the survival if the patient also had this procedure done. Bilateral mastectomy advantage, prophylactic oophorectomy advantage, and the two independent. But let's see the subgroup analysis in patients who had the risk reduction mastectomy, and you can see that the benefit is in all group age, of course, young population, less than 40 years, in all the subtype, triple negative, luminal cancers, HER2. Interesting is that the benefit was also in large cancers. So you may say, well, in large cancers, the prognosis may be due to the first cancer. So the patient may die before the second event. But if you look at the analysis, you can see that also in not early cancers, the benefit was evident. in this population. So the conclusion of the study was that risk reduction mastectomy, risk reduction of orectomy can improve the survival in the BRCA patients. Independently, BRCA1, BRCA2, it doesn't matter, probably more in BRCA1, but we may have a bias in this situation. We know that the relapse in triple negative that may occur in BRCA1 patients is usually an early situation, early relapse. So probably in doing the prophylactic surgery, patients without metastatic cancer were selected, and the reason why we may have an improvement in the survival in these patients. There was another paper done at the same Lancet Oncology journal regarding the oophorectomy, data from the National Cancer Registration dataset showing that prophylactic oophorectomy was of benefit. In these patients, in this population, the age was a little older, 45 years old, and you can see that there is a benefit in the all cause of mortality, breast cancer specific mortality, not breast cancer specific mortality. Interesting, this study was focused on the possible complications, side effects, possible, I would say, possible sequelae of the prophylactic oophorectomy. We know increased risk of cardiovascular events, increased risk of possible osteoporosis. But if you see the distribution of the sequelae, side effects, cardiovascular, there wasn't a significant difference in patients with bilateral salpingo oophorectomy versus the non-prophylactic surgery, probably a little more depression after the oophorectomy. So these studies may definitely change the clinical practice. The bilateral mastectomy and oophorectomy is, of course, now a treatment of choice. You may say, well, intense surveillance may be the same, but may impact the quality of life. Second cancer, triple negative second cancer in BRCA1 may really impact the quality of life of these patients. Ovarian cancer surveillance may not be effective in early stage ovarian cancer. I had the privilege to do a commentary on these studies in Lancet Oncology, and my mainly open question concern was, of course, I mean, let's say that the patient is 30 and she would like to have children, and of course it's difficult to calculate the timing of the oophorectomy. We see some early ovarian cancer in this patient, but of course we need to consider the desire of the patient to have children. And also important is the quality of life, because of course if we do the prophylactic oophorectomy in a 35 years old, we may impact the quality of life of this patient. So is a possible hormonal replacement therapy in triple negative cancers, BRCA1 triple negative, is something that we may consider in these patients, and of course is an open question. We published in 2003 not a guideline, but a sort of possible recommendation for patients who would like to try to save the breast and being BRCA positive, and we identify some high risk patients, high risk factors like young age, very high family history for breast cancer, Ashkenazi, Maori in CDH1 mutation, in which probably the prophylactic surgery can have the most benefit. In other situation, more than 60, 65, negative family history, of course, with mutation may not be useful. And I would like to spend some minutes on the so-called BRCA mutation, because what's happening that we are testing more and more, and we are having this more and more BRCA mutation in which we don't know unknown significance in breast cancer. We don't know if they are deleterious or not. And the convention now is to consider this mutation not deleterious. So when you have the answer of this mutation, the recommendation is not to take action and to consider the patient without the mutation. But look at what may happen over the years. In about 7% of this situation, the BRCA mutation may be reclassified as a deleterious mutation. And this is important for the patients, of course, and also for the medical legal, because if you don't inform the patients and the patient has breast cancer, of course, the patient may be upset and may suit you because you didn't inform the patient. Last two slides about the possible mastectomy, conservative mastectomy. It means is nipple-sparing mastectomy, something that we can do, is safe. And this our study, this is just data that were available last week regarding our cases. We did more than 1,200 prophylactic surgeries, contralateral prophylactic surgery in 71 of these patients who had breast cancer, nipple-sparing mastectomy, and one of the largest number in the States with a very quite good follow-up, more than 80 months, median follow-up. And we had a very, very good outcome, 0.3% of local recurrences, and this is the survival, 99%, the recurrence-free survival, 99.1%, the specific survival. So we can say that the nipple-sparing mastectomy is safe on these patients. Thank you so much for your attention.
Thank you, Dr. Sacchini, for your excellent lecture. We can make one question. Javier.
Sí, bueno, muchas gracias, doctor Sacchini, de verdad, excelente presentación como siempre. Quería hacerle una pregunta con respecto, hay varios estudios ya desde hace varios años con respecto a la posibilidad de retardar el tratamiento adyuvante en aquellas pacientes que lo ameriten por hacer una cirugía un poco más larga, sobre todo cuando la haces contralateral en su caso. Y quería saber cuál era la posición de su institución y la suya personalmente.
Thank you. Grazie mille. I would say that sometimes we don't have the test available, or the test available may be delayed, and we proceed in doing the lumpectomy. We wait for the test. We do the adjuvant treatment. First, we complete the adjuvant treatment. And then when the test is available, if positive, we don't do the radiation, of course, and we do the prophylactic surgery. So you're right, we may delay the prophylactic surgery when everything is completed, especially if the patient will need an adjuvant treatment because of high risk.
Thank you very much. Muchas gracias.
Thank you.
Thank you. Gracias, Javier. Thank you, Dr. Sacchini.
Muchísimas
Cari,
gracias
continuamos.
y acá estoy presentando ya, acá ven mi presentación, Darío. Vamos con aplicaciones de la mamografía con contraste en pacientes con cáncer de mama. Lo va a presentar el radiólogo del Weill Corner Medicine, el doctor Christopher Comstock, y los moderadores, el doctor Darío Sheckman y la doctora Karina Pese. Dejo de compartir para dar paso a la conferencia del doctor Comstock.
Good morning. Can you see my slides?
Yes.
I'm going to talk now about a new technology, contrast mammography, which we have used quite extensively over the past 12 or 13 years at Sloan-Kettering, and Dr. Sacchini is very familiar with. And now branching out, Weill Cornell is about to start offering it, as well as other centers in New York. And I'm going to try to focus primarily on the new applications of contrast mammography that could apply to the breast cancer patient, either preoperatively, looking at response to therapy, and screening those patients. Here are my disclosures. So firstly, I'll just talk about the basic techniques of contrast mammography and then go over some of the indications, and with each of those indications, the data. And some of the indications would include extent of disease, so preoperative evaluation similar to preoperative MRI in the known breast cancer patient, assessing response to therapy, and then also screening patients post-lumpectomy, screening for breast cancer and supplementing that with contrast mammography. And then lastly, I'll just talk a few points about implementing contrast mammography at your center. Now, you'll see the term CEM, which contrast enhanced mammography, or you'll see CEDM, contrast enhanced digital mammography, and sometimes you see contrast enhanced spectral mammography, CESM. And but it's all the same test as contrast mammography. Now, we know that the sensitivity of standard mammography and even tomosynthesis is limited the higher the breast density of the patient, which obviously in the higher density categories, the sensitivity drops off significantly. And that's just because that dense tissue can obscure cancers and lower the sensitivity. Now, the beauty of contrast mammography is that it allows you to see the vascular changes, which occur at a much smaller tumor size than mammography or tomosynthesis or ultrasound, where you're looking for the morphology of the tumor. And in order to see that and detect those tumors, they tend to have to be on a larger size. So the beauty of contrast imaging, which includes MRI and CEM, is that it's not limited by breast density, and that's where the big advantage comes in. So how is contrast mammography performed? Well, it really came about 12 or 15 years ago by something called dual energy technique. And the problem 25 years ago, when people started to try contrast mammography, particularly at the University of Colorado, John Lewin and his group, that was called time of flight contrast mammography, where basically you did a mammogram, then you gave contrast to the patient, and then you repeated the mammogram. Well, the problem is you can't match the mammographic views, the craniocaudal and the LMO views. The positioning is always going to be a little different. So that really never worked out. You could do it on a single view where you positioned the patient, you took a mammogram, you kept the patient in position for that view, and then you gave contrast, and then you could do a post-contrast view, but it was very primitive. Well, so dual energy basically is performed after the administration of contrast, which is the same as a CT scan iodinated-based contrast agent based on weight. And the dual energy, there's two exposures during the mammogram, one below the K edge of iodine and the other above the K edge. So the low energy is the photons are not absorbed And so you don't have attenuation where there is any contrast. At the higher energy, where they are able to cause a photoelectric effect of K-shell electrons, then you have absorption, and that higher energy image tells you where contrast has been attenuated. And so you have both the low energy image, which is a traditional 2D mammographic view, and then you have a contrast image all in one study. For the patient, obviously you need a mammographic unit that's capable of dual energy or spectral mammography. And most modern units are upgradable without a lot of cost or changes. So there's a minimal upgrade, but it allows your mammography unit to do this dual energy. And so for the patient, the mammogram seems very similar to their regular mammogram. In fact, they probably won't know much of a difference other than getting a contrast injection of iodine about 2 minutes before. There's a 2-minute delay, and then the start of the standard mammographic views, the MLOs and the CC views of each breast. But during those exposures, there are instantaneous 2 exposures occurring, actually, the high and the low energy. And so the entire study is completed within about 7 to 10 minutes. And so here's an example of the low energy on the left, then the high energy, which has that information about the iodine attenuation, and that results in what we call the recombined image or our contrast image, which shows where there's iodine uptake. So let's look at some of the clinical indications. Well, we particularly at the various centers I've worked at, we really haven't used it, although some centers use contrast mammography in a diagnostic setting, so patients with palpable lumps or callback from screening mammograms. Some centers do use contrast mammography for that, but I think really the benefits are in the other indications. The bigger benefits are preoperative staging, evaluating response to therapy, and then screening patients at intermediate to average to intermediate risk. Now, patients who fall under the high risk or gene carriers or BRCA 1 or 2 patients, those patients tend to already be getting mammography and full MRI. So generally, we would do this contrast mammography on patients who are in that average or intermediate risk who don't qualify for MRI. So let's just look at preoperative staging. Obviously, the same debate can occur with, as you have with whether or not to do preoperative MRI. Some centers use it quite extensively and other centers do not. But if you do believe in preoperative staging with a contrast type study, contrast mammography is very similar to MRI, preoperative MR, in that it can identify the extent of the index lesion, look for additional multifocal or multicentric disease, and also evaluate the contralateral breast. There was an early study by Dr. Jockelson and Dershaw in 2013. It was a small study, but it showed that mammography, contrast mammography, and MRI, these are patients who have a known breast cancer and volunteered for both MRI and contrast mammography, that the index lesion was detected similarly by both. Now, the additional lesions, the MRI had a higher sensitivity, which we'll see as a recurrent theme, that MRI tends to be a little bit higher sensitivity than contrast mammography, but that the CEM, the contrast mammography, was more specific with less false positives. Here, the MRI had 13 additional biopsies that were benign versus only 2 out of 52 with the contrast mammography. So here's just an example of a preoperative staging, a patient with a known cancer. The MRI shows that localized cancer, and here's the contrast. This is an early, the technique has improved since this, but this shows you that same vascular-based image of the tumor using contrast mammography. Here's another example of a patient thought to have localized disease in the left breast, and here's the extent, much more extensive seen on the MRI, and we see with the contrast mammogram that we see the same pattern and extent using the contrast mammogram. So now comparing the sensitivity and specificities again in patients with known cancer, looking at additional disease, Fallenberg published in 2017. Again, that same kind of pattern we're seeing, that the contrast mammogram has a bit more sensitivity, but the MRI has a bit more sensitivity, for those additional lesions, but the specificity was better for the contrast mammogram. What about invasive lobular? Patients with a known invasive lobular disease. This was Lobes et al. In 2023. And again, it showed the MRI had a little bit more sensitivity, both significantly higher than standard mammographic evaluation, but the specificity of contrast mammography was a little bit higher. So that's in terms of access, time, and cost, and I'll talk about this at the end. Contrast mammography is very readily available, and it allows fairly good evaluation of extended disease, pretty comparable to MRI. And again, it's a single test where you have both contrast and a mammographic image in one test versus with MRI or preoperative MR, it requires both a mammogram and the MRI to have both the mammographic and vascular imaging on the patient for extended disease. So response to therapy is another area which has been studied at several centers. The bottom study was one done by Zhao Horvat et al. At Sloan-Kettering, and it showed that this was evaluating patients with known breast cancer and then looking to compare contrast mammography versus mammography and MRI in evaluating post-therapy, how much residual disease or predicting the response. And we can see that the MRI, again, slightly higher sensitivity, but the contrast mammogram, a little bit better specificity. And that resulted in a little bit 60% negative predictive value versus for MRI versus 50% negative predictive value with the contrast mammography. But the sensitivity was pretty similar, 81 versus 88%. So here's just some examples of the role of contrast mammography for a response to therapy. Here's a contrast mammogram after therapy showing a fair amount of residual enhancement. So this doesn't look like a great response. We can compare that to MRI. And again, MRI shows significant residual, so only partial response here. But you can see the pattern and extent is pretty similar with the contrast mammo versus MRI. Now, what about this patient, a 54-year-old with a palpable cancer? It was treated with neoadjuvant therapy. And now here's the post-therapy standard mammogram. And we see the marker clip where the tumor was. We do see a little bit of asymmetry. Now, is that residual disease or is that just inflammation from the response? And so now in the same patient, if you look at the contrast image, we see that there is no enhancement. And so this is a good indicator that this has been a complete imaging response and a probable complete pathological response. So lastly, I'm just going to finish. So we've looked at the role of contrast mammography for preoperative extent, and we've looked at using that for response to therapy. Lastly, what about contrast mammography for breast cancer screening, and particularly in your patients who have post-lumpectomy? They're kind of intermediate risk. Maybe they don't fall into that high-risk category that qualifies or gets insurance will pay for MRI. Those intermediate risk post-lumpectomy patients with dense breast tissue, contrast mammography can be quite an improvement on the screening sensitivity going forward after their lumpectomy. And here's just some examples where we see the contrast mammography has a pretty high incremental cancer detection rate. Janice Sung published in 19 from Sloan-Kettering, almost 7 additional cancers per 1,000 not detected on mammography using contrast mammography. Now, there have been some pretty high ones here, over 23 additional cancers per 1,000, and Soren et al. At about 13 additional cancers per 1,000. That's on the incident round, the prevalence round screening. So we see that there's a comparison from ultrasound, contrast mammo, and MRI that there's not quite enough data yet. I didn't put in a slide. There was a recent BRAID trial out of Fiona Gilbert out of the UK, which showed pretty comparable screening results, although it wasn't powered to compare contrast mammo and MR, but showed in that study where there were 3 arms of ultrasound, mammo, and MRI, contrast mammo and MRI, that the contrast mammo was a pretty similar detection rate. but you can see the range varies just partly because we don't have a lot of data. I'm currently running a multi-center trial called CMIST, and that's comparing tomosynthesis with contrast mammo for cancer detection in average risk women for screening. That's about a 2,000 patient study, and we've accrued about 700. So more data to come on contrast mammography for screening. So here's just an example of a very challenging mammographic pattern. Be hard pressed to find any cancer in that. But now when you look at the recombined contrast image on that same patient, we can easily see that small 12 o'clock axis invasive tumor. Here's a patient, and there's the targeted ultrasound. Here's a patient again, post-lumpectomy and radiation therapy. Traditional mammographic views showed post-surgical changes, but no abnormalities. And now here, the contrast images, we can see some enhancing foci extending anterior to the lumpectomy site. And that turned out to be residual or recurrent carcinoma. Here's the targeted ultrasound. And here's another one, post-therapy, lumpectomy in the medial upper inner left breast, very dense pattern. And here's a small enhancing mass seen, not seen on the traditional mammography, but on the contrast images. And then that was, this was before we had contrast mammography guided biopsy. I don't have time to go into that, but that really came about in the last 6 or 7 years. And so now it really allows contrast mammography to be a standalone with its own biopsy methods rather than relying on MRI. So it's important if you're going to embark on contrast enhanced mammography that you add that contrast mammography biopsy capability, which usually is included in the software package and the equipment package. So here, before we had the ability to do contrast guided biopsy, obviously we'd look with ultrasound first. That was negative, and so the patient had there was MR was seen, that was seen on MRI, and it was biopsied under MRI. So lastly, clinical implementation. Obviously, you need a system that's upgraded to this dual energy technique for contrast mammography. You need the power injector and iodinated contrast, similar to it helps if you're performing this in a center that also has a CAT scanner, because they're familiar with this and have the equipment. And obviously the sharps containers and IV setup and everything for the patients. So there is some things, obviously, patients you need to check if they have certain history for, just like with a CAT scan, renal disease, metformin, diabetes, and age may prompt you to do creatinine or GFR prior to the test. But so another question becomes, what about contrast mammography versus abbreviated breast MRI? And the big benefit of contrast enhanced mammography versus MRI is access and availability. On the bottom here, you see the left is the number of mammographic units. Now, these aren't contrast mammography units, but most of these systems could be easily upgraded, versus on the right, you can see the limited availability of MRI. As I mentioned, really, MRI also, to have high sensitivity, patients who are getting screening with MRI still need to do a mammogram. So that's 2 tests or 2 appointments, versus in a contrast enhanced mammography, that's a single study. The time, cost, and obviously the familiarity of the patient to screening mammograms is a benefit. If you're doing MRI and mammography, if you're doing contrast enhanced mammography, you really don't need to do a screening ultrasound. You can do away with screening ultrasound. This was, again, a paper by Horvat et al. At Sloan-Kettering in radiology. It showed the extra detection of contrast mammography, and it found all the cancers on ultrasound. So just a caveat, you don't need to do both. Payment. Contrast mammography can be paid as a diagnostic study because that's what it's FDA approved in the United States. So preoperative, response to therapy, diagnostic workups. The only issue is screening. Now, your lumpectomy patients can be put in as a diagnostic for several years after lumpectomy, but later on, you may have variable reimbursement because you may have to bill it as a regular 2D mammogram and then bill for the IV push for the IV contrast. And that sometimes doesn't get paid in its entirety, but something that will be worked out in the future as this gains acceptance. So just to finish off here, contrast enhanced mammography offers definitely improved sensitivity over mammography and ultrasound. You could consider this as an alternative to MRI, which is higher access, lower cost, quicker study. And you can offer that in your breast cancer patients for preoperative evaluation, response to therapy, and then post-lumpectomy screening in those patients with a difficult mammographic pattern, dense breast tissue, etc. So thank you very much.
Thank you, Christopher, for your nice talk. We have time for only one question. So in the same way for your last slides, and we see that the contrast mammography grow up a lot in the last 2 or 3 years, but there are still relatively few centers doing contrast mammography. What do you think that it will be passed in the future? You are mute. Sorry. What do you think it will be passed in the future? What do you think about contrast mammography against MRI? It's in the same place that MRI. And so what do you think?
Yeah, I see there's a lot more in favor right now in terms of contrast mammography because its availability, it's a very quick test. There's units that centers can start offering that easily. And they can bill in the United States, they can bill at least something versus access to MRI and the time in preoperative or extended disease or response to therapy, those get paid for. It's really in that screening, post-lumpectomy screening, cancer screening patient, the lumpectomy patient for subsequent screening. MRI may or may not be paid for. So I think that's a big impedance to MRI right now, is getting those intermediate risk patients their coverage for MRI. But I do think in terms of artificial intelligence and predicting response and the information you get on an MRI, because you have multiple sequences, you have radiomic data from that MRI, I think it's probably a more robust platform for those types of things than contrast mammography, which is just a limited, two-dimensional image.
Okay. Thank you, Christopher. We need to continue with the program. Karina, bye. Thank you very much.
Thank you. Continuamos con la doctora Kelly Hahn, que nos va a hablar sobre avances y manejo del linfedema. La doctora Hahn es jefa del Departamento de Oncología Quirúrgica Mamaria de la Universidad de Texas Anderson, Houston, Estados Unidos, y la moderadora va a ser la doctora Fernanda Barbosa. Dejo de compartir para dar paso a la doctora.
Hello, and thank you for inviting me to participate. I'm going to be talking about options for the management of lymphedema. These are my conflicts of interest, and I won't be discussing any of these relationships today. Just as an outline, I'm going to go over quickly the lymphatic system, and then the pathogenesis of lymphedema, the etiology, the diagnosis, and finally discuss some non-operative and operative treatments that are available for patients who have lymphedema. So this shows the lymphatic system. Obviously, for treatment of breast cancer, we're most interested in the lymphatic drainage around the mammary gland, especially in the axilla, and the supraclavicular and cervical lymph nodes. So the lymphatic system drains protein-rich fluid from the periphery, and we have both the afferent lymphatics, which drain into the lymph node, and the efferent lymphatic system that help to drain to and from the lymph node itself. And it's the disruption of these lymphatics and removal of these lymph nodes that can result in lymphedema. The process is first the disruption of lymphatic channels, which leads to stasis of the lymphatic fluid within the peripheral tissues. This causes an inflammatory reaction that then leads to proliferation of adipose tissue and fibrosis. And these are the areas that are more advanced lymphedema. In the US, there are about 5 to 6 million Americans that are affected by lymphedema, and that's probably an underestimate considering how many individuals are treated for cancer. And just to put it in perspective, it exceeds the total number of patients who suffer from other diseases like Parkinson's and rheumatoid arthritis and multiple sclerosis and many other diseases. It has a very negative impact on the quality of life. And there's really no cure for the disease currently. We have options for management once it's diagnosed, and there's much interest now in prevention. So, of course, when we do an axillary lymph node dissection, we know that many individuals will develop lymphedema, and it's estimated to be about 29 to 49% of patients after axillary lymph node dissection. There's quite variability in the way the axillary lymph node dissection is performed, the extent of the axillary lymph node dissection. And traditionally, surgeons have been taught to strip the axillary vein, and that is where many of the lymphatics that are running along the vein from the upper extremity will be disrupted. But of course, sometimes the lymphatics will be lower in the axilla, and the disruption of those lymphatics, even with sentinel lymph node biopsy, can cause lymphedema in up to 8% of patients. And this has been documented in many studies. Of course, other things like trauma and other types of cancer, infection, and also use of radiation can cause lymphedema. And so we see the highest rates of lymphedema in our breast cancer patients that are having axillary lymph node dissection and radiation. The first thing that we see is edema and swelling. And of course, many patients will describe a heaviness in the extremity. After this, they will start to get hyperkeratosis and skin ulcerations. And many will suffer from these infections, especially from strep, and get lymphangitis. And a very late complication is lymphangiosarcoma. So Stewart-Treves syndrome is something that was described many years ago in patients who had lymphedema of the extremity and then developed purplish raised cutaneous lesions that are the sarcomatous development in the extremity that has this chronic lymphedema. And in patients treated with mastectomy, it's usually the median is about 10 years after the surgery. Of course, this is associated with a very poor prognosis and a very poor 5-year survival rate of less than 5%. The International Society of Lymphology has developed a staging system for lymphedema. And what you can see here is that in stage 0, there's no obvious change in the limb volume if you measure it or just by looking at the patient, but the patient will often describe symptoms of heaviness in the extremity. In stage 1, there's measurable limb swelling, and there can also be some pitting edema that can resolve with compression, and so early management of this can be very important. In stage 2, this is not spontaneously reversible. The limb swelling is associated with fibroadipose tissue deposition, as I was describing earlier, and this does not typically resolve with compression. Some patients can use devices that they put on at night to help reduce the swelling, but they cannot completely reverse it. And of course, the end-stage lymphedema is one that has severe swelling and skin changes, and this is what we hope to avoid by intervening earlier. So how do we evaluate the lymphatic system? There's many different qualitative and quantitative ways to do that. one of the qualitative ways is with lymphangiography. We can also use CT or MRI imaging, ultrasound. Lymphoscintigraphy is typically used by injection of radioisotope. And then more recently, many are using fluorescence lymphography by injecting ICG. And for quantitative measurements, the traditional way has always been circumferential measurement. Now, this is often dependent on the individuals who's doing the measurement and whether it's done at the same intervals along the extremity. And so there can be differences in measurements from individual to individual. There's also volumetry, tonometer, and quantitative lymphoscintigraphy. More recently, bioimpedance spectroscopy is a little bit easier way of measuring it, but of course is associated with more cost. In lymphoscintigraphy, typically technetium-99 is injected in the dermis. It takes from anywhere from 5 minutes to 2 hours, and it's a transportation index so that you can look at how quickly things are moving through the lymphatic system. ICG laser angiography is indocyanine in green, injected in the subdermal injection. And then you have a laser that can penetrate 1.5 to 2 centimeters. You can see the different types of findings here: linear, splash, stardust, and diffuse. And it's also a transportation index, and it can be used intraoperatively for the surgeon to evaluate the lymphatics for surgical intervention. And then there's MR lymphangiography, which is a complete evaluation of the extremity, can also look at venous evaluation, and it can also assess the fat and fluid component, because again, the more fat and fibrosis in the extremity, the more advanced and more difficult it is to treat the individual with lymphedema. So in terms of medical treatments, weight loss has always been suggested, although many individuals will find this difficult, especially in our breast cancer patients who are receiving endocrine treatments that might make it more difficult for them to lose weight. The traditional thing that our physical therapists use is complete or complex decongestive therapy. And when done very early stage lymphedema, this can have a very significant impact and be very effective in management, but not necessarily cure. So this is the manual lymphatic drainage, and usually also requires daily bandaging or wearing garments, which can be very problematic for many of our patients. Exercise can also very much help with this. Even weightlifting, which traditionally was thought to be worse for people who have lymphedema, it actually can help reduce lymphedema. And then very important, hygiene and skincare to prevent those extremity infections that are associated with lymphedema. Some medications, such as diuretics, can help, but obviously not cure lymphedema. There's been some studies looking at non-steroidals and vitamin E for prevention or treatment of lymphedema. And there's been some effect of this, but not curative. So what about surgical treatment? There are debulking procedures such as liposuction, which can help some individuals for a period of time. And then there's more physiologic procedures such as lymphovenous bypass and vascularized lymph node transfer that can help restore the lymphatic drainage to the affected extremity. So this just shows an example of an individual who had liposuction for lymphedema of the lower extremity and how effective that can be, even up to a year. But again, patients will start to have the lymphedema again and require ongoing management and treatment. Surgical treatment such as lymphovenous bypass has been popularized over the last decade or so. And typically the way this is done is with lymphozurin blue intradermal injection, where you can identify the lymphatics and then connect them with one of the venous tributaries in the extremity. It does usually require superfine microinstruments to find the lymphatics in the veins. And the anastomosis is done with a very fine suture, usually 11-0. And this is just some examples of how this can be done. Lymphovenous bypass with intraoperative imaging using fluorescent lymphography, intradermal injection of ICG dye into the web spaces of the hand and the wrist and in the affected extremity to identify the lymphatic channels. You then can use a marker to map the lymphatic vessels, identifying the location of open channels, as well as where the blockage is seen based on the imaging. And then there's a vein viewer, which is a near-infrared vein visualization device that helps to find the adjacent superficial veins for the bypass. So this just shows an example of the procedure where the lymphatic's been identified in the vein, and then the anastomosis is performed. And you can see here the anastomosis after completion. And just for perspective, each one of these squares is 1 millimeter in size. So the microscope obviously helps to magnify this for the surgeon to be able to see. And then you can also verify patency. So filling an ICG. So in this case, using ICG, you can see that the lymphatic is going into the vein, and you can see here easily that it's patent. And so that is a very helpful tool when the procedure is being performed. So there's a growing number of studies that are demonstrating the efficacy of this lymphovenous bypass in the treatment of lymphedema, and most of them show anywhere from 35 to 50% reduction in the extremity circumference. So again, reduction, not necessarily a curative procedure. David Chang at University of Chicago has reported 96% of patients reporting subjective improvement in symptoms, and mean volume reduction at 12 months was 42%. A smaller subset was followed for 3 years, and the reduction remained at 38%. So some impact, but obviously not effective for all patients. And from my colleagues who do this regularly, they tell me the earlier it's performed, the better the results. What about lymph node transfer? This is another tool that can be used for patients typically who have more advanced lymphedema. It's more powerful than lymphovenous bypass, but it does require harvesting lymph nodes from another site. So from a remote donor site, and then transplanting them into the limb that has lymphedema. The lymph nodes are vascularized, again, by microvascular anastomoses to recipient vessels to maintain their blood supply so that they're fully functional. And so the goal is to restore that physiologic lymphatic flow, not only of the lymphatics themselves, but also that powerful lymph node drainage. And so there's many different donor sites, which you can see here. Most typically, groin, supraclavicular, and omentum are the sites that are used for the lymph node transfer. And this just shows an example of the patient being prepared for harvest of a supraclavicular lymph node for transfer. And then this is the vascularized omental lymph node transfer. It's based off of the gastroepiploic artery. It can be harvested either open, laparoscopically, or robotically. It has a very abundant supply of lymph nodes, and there's no risk of donor site lymphedema with this flap. So that's obviously a big advantage. And you can see here some of the lymph nodes within the omentum. It can also be divided into 2 flaps for dual level transfer. And the disadvantage, of course, is that it requires an intra-abdominal harvest, which is another potentially complex operation for the patient. It was first described actually in the 1960s, and this is just from one of those original publications looking at chronic lymphedema of the extremity and placement of the omentum for transfer. The omentum has several properties that are advantageous for this, including immunologic properties. There's peritoneal B cell and IgM production, angiogenic. There's an abundance of vascular endothelial growth factor and associated lymphoid tissue. There's a network of capillaries and other immune cells and the mesothelial in the mesothelial envelope that are called milky spots. And so this is a diagram just showing the anatomy using CT tomographic angiography, and the lymph nodes that are available here along the gastroepiploic artery, there are multiple lymph nodes there that can be utilized, and you can see here the identification of those lymph nodes. The vascularized lymph node transfer procedure shown here, again, requires very superfine instruments and a microscope. There's also something called the double vascularized omentum lymphatic transplant, or VOLT. Very powerful procedure that's been described by these authors. And again, a more complex procedure. This just shows where they've harvested the omentum from the upper abdomen. And again, more recently, this is being done robotically or laparoscopically, so not requiring a formal laparotomy. And this just shows the example of the imaging after harvesting and where it can be placed. From this group at Memorial Sloan-Kettering, they did 54 patients, and 16 had a double volt, and they demonstrated a significant reduction in cellulitis from 45% to 13%. So typically this is utilized for patients who have recurrent infections and significant lymphedema. It does require, a general surgeon or surgical oncologist to do the laparoscopic harvest, and the anastomosis can be done in the upper extremity to the thoracodorsal vessels. It can be done in the lower extremity as well. Usually patients need to be at bed rest for a period of time, and then they have to restart their compression with and work with the certified lymphedema specialist in order to see the best result with this. It does appear to be a safe therapy for lymphedema. It's associated with resolution of cellulitis, as I noted from the publications, and improved patient-reported outcomes, but it does also have a more complex requirement for that harvesting of the omentum, but doesn't have other donor site morbidity. Some have, again, this is from David Chang. He's described the combined DIEP flap with a vascularized lymph node transfer. This is where they have simultaneous reconstruction that can provide patients with breast reconstruction from the deep flap, but also relief of their lymphedema by using a vascularized lymph node transfer. But it should be used with caution, obviously, because you can get iatrogenic donor site lymphedema. And so it's very important to use preoperative imaging to identify the sentinel lymph nodes draining the leg so that you can prevent donor site lymphedema. We don't want to replace upper extremity edema with lower extremity edema. So the vascularized lymph node transfer has become more popular for those patients with very significant lymphedema and long-term complications such as infection. It's a very powerful donor site, and it can be combined with DIEP flap in patients who have post-mastectomy lymphedema and need reconstruction. We also have the lympho procedure, which was first described by surgeons in Italy using a lymphatic microsurgical approach for primary prevention. So this is, as opposed to treating lymphedema once it's already evident, this is using prevention by identifying lymphatics from the arm and connecting them to venous tributaries from the axillary vein at the time of surgery. And this is shows some of the results from these from the lympho procedure, lymphedema rate of being 4% as opposed to 6 to 13% with sentinel lymph node surgery, or 13 to 65% with axillary dissection. There have subsequently been a number of reports of different institutions utilizing lympha for prevention of lymphedema, and this is becoming more popular, especially as we're de-escalating axillary surgery in many patients, but some patients will still require axillary lymph node dissection, especially those with inflammatory breast cancer or more advanced nodal burden. So immediate lymphatic reconstruction, again, identifying the vessels and the appropriate donor vessels and the lymphatics that will be reconstructed. This just shows the anastomosis between the lymphatic and the vein here. And again, looking at flow into the anastomosis, and you can image this as well to demonstrate that it's effective. This is also a publication looking at the impact of radiation and lympha. So how much does the radiation treatment in many of these patients with advanced disease impact the lymphatic flow in this reconstruction? So this was literature review and meta-analysis, 19 studies, over 700 patients. And what you can see is that the incidence of lymphedema was, when lympha was used, was less when patients had axillary lymph node dissection with lympha, and even in patients who had radiation after axillary lymph node dissection. So lympha is the first attempt at reconstructing those injured lymphatics at the time of lymph node dissection. It does reduce lymphedema and reduces early complications, but it requires cooperation between the breast and plastic surgeons for harvesting of the lymphatics. At Memorial Sloan-Kettering, they have published a different approach where the surgeon performs the axillary lymph node dissection, and then the plastic surgeon does evaluation of the lymphatics following the surgery using ICG, and they did a randomized trial. This was published in Annals of Surgery, looking at 72 patients who were randomized to immediate lymphatic reconstruction and 72 to control, so no lymphatic reconstruction. And they saw that lymphedema was decreased from 32% to 9.5% in those that had immediate lymphatic reconstruction. Again, they used bioimpedance and found that also patients had decreased compression usage and better lymphatic function when they looked at ICG lymphography, and better quality of life than the control group. Many centers, including my own, are using axillary reverse mapping at the time of surgery, so injecting the blue dye in the upper extremity to identify the blue lymphatics coming into the arm, then removing the lymph nodes at the time of surgery, whether it's sentinel lymph node surgery or axillary lymph node dissection, and then reconnecting the lymphatics, the blue lymphatics from the arm, to branches of the axillary vein. And you can do this to potentially preserve the blue lymphatics and lymph nodes, but if you find that there's crossover, which we do find from time to time, so you inject isotope in the breast, and if you find that there's isotope uptake in the blue node that's draining the arm and is also isotope drainage from the breast, then usually that lymph node will need to be removed, because there can be it can be both an arm lymph node and a breast lymph node. This just shows the procedure here, one of our plastic surgeons, where we've identified the lymphatics and then they've completed the lymphovenous bypass, which you can see the blue dye going through here, and very effective. We also participated in the Alliance trial, which is a randomized trial of patients getting arm, axillary reverse mapping at the time of sentinel lymph node biopsy or axillary dissection versus those that do not have the axillary reverse mapping. The trial has been completed, but we're still awaiting the results to mature to see if this is an effective method of decreasing lymphedema. So breast cancer-related lymphedema is obviously very problematic. We have treatments for it. We have the use of different techniques like lymphovenous bypass for treatment. And again, that's something that is effective but cannot cure it. But we can sometimes consider this for prevention as well. And then we also have the use of vascularized lymph node transfer, and that also for reconstruction at the same time, or lymphovenous bypass is a primary procedure. So I want to thank my colleagues in plastic surgery and others who showed me many of their techniques and provided some of these slides. And thank you again for the opportunity to share this with you today.
Thank you, Dr. Hunt, for your lecture. And Dr. Fernanda Barbosa, can you make one question?
Yeah, thank you, Dr. Hunt. It was amazing, your lecture. So as you brilliantly explained in your lecture, lymphedema, it's so different to treat, and the best way is to prevent it. So my question for you is, do you do there at MD Anderson something to stratify like a higher risk patients that will develop lymphedema? Do you have any approach for them like before surgery, like physical therapy, and also right after surgery? Do you do that over there?
Yes, thank you for that question. I think that we know that our highest risk patients are those with inflammatory breast cancer, where they already appear to have some lymphatic dysfunction before, even before we do the surgery and radiation. And certainly patients who also get chemotherapy are at higher risk. And so typically we do have a very standardized approach for those patients with more advanced disease. And we do have them see physical therapy. They're very big partners in all of this. And then they have measurements. We typically do all of the lymphedema measurements before any interventions. So we get baseline measurements, and then after different, when they come back in preparation for surgery, and then also after radiation therapy. So we can follow the timeline of the treatments and how those impact the incidence of lymphedema. I think also it's very important, in these patients who have very advanced nodal disease, where we're doing, a level 1, 2, and sometimes level 3 lymph node dissection because they have extensive nodal metastases. And we know they're also going to get extensive radiation treatment afterward. And those are the patients that we're really focusing on, as opposed to maybe those lower risk patients, like patients just having sentinel lymph node biopsy.
Thank you. Thank you very much, both. Okay, we will continue with the program. Cari.
Sí, Darío. Acá
Okay.
estoy viendo mi presentación.
Sí. Ok, creo que tenemos ahora 5 minutos de pausa para el que quiera estirar, relajarse, tomar un café. Mientras tanto vamos a mostrar un poco lo que estamos haciendo. Cari,
Y
no sé
vamos
si
a
querés comentar de
compartir
esto.
también, Darío, el link para que la gente se pueda anotar al libro para recibirlo. Acá que nos van a abrir el chat, lo vamos a compartir y también vamos a compartir el código QR, ¿te parece?
Me parece. Está abierto el chat también para que puedan conectarse.
Bueno, comenzamos presentando entonces la actividad que vamos a hacer con la comunidad latinoamericana de imagenólogos mamarios, que va a ser del 27 al 29 de marzo del 2026. Los directores, el doctor Darío Sheckman y quien les habla, la doctora Karina Pese. Quienes ya vivieron la modalidad en abril del 2025 saben que es una actividad súper personalizada, por lo cual hay cupos limitados. Nuestra página web es climlatam.org y este es el mail de contacto, @climlatam.org, y quienes quieren participar pueden inscribirse a través de este código QR. Y esto es lo que van a vivir en el curso de CLIM.
Va a haber práctica donde van a poder trabajar tanto con mamógrafo como con ecógrafo, con las estaciones de trabajo, o sea, va a ser algo inclusivo, intensivo. Van a poder hacer biopsias con fantomas, tanto por mamografía como por ecografía. Va a haber también fantoma para hacer contraste. Y va a haber análisis de casos complejos, casos cotidianos, lo que vemos día a día en nuestro trabajo. Realmente Estamos muy conformes, muy contentos por lo que salió en el año 2025 y tenemos muchas nuevas sorpresas para el año 2026.
Bueno, estos son los aranceles del curso. Va a haber una inscripción temprana que es hasta el 1 de diciembre, que tiene un costo de $450, incluye la cena de bienvenida, material del curso, todos los talleres prácticos. Todo esto va a estar disponible hasta el
En la
1 de
página web.
diciembre. Este arancel, que van a ahorrar un 30%, acá tienen la posibilidad del QR. Después va a haber una inscripción regular que va a ser del 2 de diciembre al 27 de febrero y la inscripción tardía si es que quedan cupos, porque dado la experiencia que ha sido del 2025, generalmente quedan en lista de espera y a veces no llegan a inscribirse. También vamos a tener la posibilidad de fraccionar el pago para quienes lo necesiten y grupos de 4 o más participantes puede haber un arancel especial. Esto ha sido la actividad que se ha vivido en Miami en marzo del 2025. Países, médicos, profesionales de toda Latinoamérica han participado. Y vamos a tener, Darío, el curso Clean Brasil, ¿no?
De Clean Brasil, que va a ser en el mes de ahora de septiembre, son 3 días. También si quieren, después vamos a compartir el link para anotarse, es en forma gratuito. Y son 2 días online y hay un día que es presencial. Y tenemos también creo que el libro, no sé si Gabriel, ¿querés comentar algo del libro? Está
El libro,
muteado.
no estoy muteada yo.
No, Gabriel.
Ok.
Ahora,
El,
bueno, yo simplemente para decirle que realmente es simple, es un libro de 100 páginas, no es muy pesado, o sea, es bastante ágil para leer y es como la radiografía de todo el trabajo que se realiza continuamente cada día en el Instituto Europeo de Oncología, que con todas las especialidades, disciplinas que hay que tratan el cáncer de mama, realmente es una producción que está convirtiéndose año tras año en un verdadero manual pequeño, no pesado, como he dicho, de 1000 páginas, sino de 100, 150 páginas. Y ya estamos en la segunda edición del mismo libro y probablemente el año próximo hagamos la tercera. Ya salió en inglés, está por salir en italiano y en castellano, que está pronto ya está impreso y está a la distribución, está listo para la distribución. Bueno,
acá quienes escaneen el código QR se pueden inscribir en un formulario. También si me habilitan el chat, por favor, yo puedo compartirles el link porque por ahí les resulta más fácil.
Está habilitado, Karina.
No puedo, está el mío, solamente panelistas. Si me habilitan, puedo para todos compartir.
Es importante decir que es gratuito. Es
gratuito,
claro,
exactamente.
Eso es lo que quería decir.
Material de alta calidad científica, pero gratuito.
Exacto, eso es importante saber, que solamente tienen que bajar el link o comunicarse con el link que les va a copiar Karina en el chat para que ustedes lo puedan hacer, pero realmente es un aporte importante del Instituto Europeo de Oncología a través de Gabriel, que nos da todo el acceso a este libro en forma 100% gratuita.
Bueno, yo lo puse en el chat de panelistas porque no me deja para todos, no me sale esa opción, así que Ethel, por favor lo copias y lo podés pegar para que lo puedan tener todos. Ahí te lo pego.
Ahí creo que ahí yo lo mandé, ahí también lo mandó Ethel. Ethel, muchísimas gracias.
Muchas gracias.
Bueno, Gabriel, Karina, no sé si les parece, por honor del tiempo, continuamos.
Perfecto.
Continuamos con el programa. Han tenido tiempo para tomar un pequeño café, ir al baño, que siempre nos piden esta pequeña interrupción y continuamos ya con el programa si tratamos de terminar en tiempo. Bueno, continuando con el programa, vamos a hablar de la utilización de la biopsia líquida en cáncer de mama con énfasis en la enfermedad metastásica. El doctor Pedrán Razavi, nos va a dar la charla. Es del Departamento de Medicina del Memorial Sloan-Kettering Center de New York. Y el moderador va a ser el doctor Carlos García Gerardi. Doctor Pedrán Razavi, if you want to share your presentation.
Can you see my presentation?
Yes.
Fantastic, fantastic. Let me minimize this. So thanks so much for the invitation. Really delighted to be here and present some of my thoughts and some of the recent data on utilizing liquid biopsy with an emphasis on metastatic breast cancer. Last year, I presented mostly on the early stage disease. I will provide some updates on the metastatic setting at this point. So these are my disclosures. So the landscape of precision oncology in breast cancer has completely transformed in the past 10 years. We are now having multiple targeted therapies, multiple biomarker-driven therapies that we offer our patients. We monitor the patients using genomics, liquid biopsy, and other means. And also on the research side, on the translational side, we try to understand why some patients respond to treatment, some not, utilizing animal models, xenografts, liquid biopsy, so on and so forth. So I will have a talk mainly on the liquid biopsy aspect of it. But I would like to highlight the fact that, as we started utilizing these genomic analyses in the clinical setting, what was very obvious was the gap between what we knew and what we didn't. There were alterations in the genes that we didn't know about and needed to be clarified. And there were some genes that have never been implicated in breast cancer or resistance to certain therapies. So put together a program at MSK called Translational Breast Oncology Program. And in that program, we decided we try to understand these mechanisms of resistance through analysis of real-world clinical genomic data. Some of my other colleagues from other centers have done the same thing as well. And this resulted in significant improvement in our understanding of mechanisms of resistance to endocrine therapy. Obviously, we know about ESR1 mutations that were discovered by Surratt and others and result in independent activation of ER, but MAPK alterations, some multiple transcription factors, so on and so forth, have been implicated also in resistance to endocrine therapy. And also our understanding of CDK4/6 resistance that they're introduced in our care only in 2015 have significantly improved in the past 10 years. Now we can explain probably 60%, 70% of intrinsic and acquired resistance to CDK4/6 inhibitors through genomic means only, which is a major improvement from what we had in 2015. And the question here is, can liquid biopsy help us identify these resistance mechanisms, identify the evolution of disease, and also help us identify actionable alterations? As you know, multi-regional tumor biopsies are not feasible. Serial biopsies are even not feasible in majority of our patients. Can we use liquid biopsy in that setting? And the answer is yes. We've been using liquid biopsy very effectively in metastatic setting to identify actionable alterations. We've been adding reflecting to tumor sequencing at the time that liquid biopsy was not feasible or but the results were not appropriate because of the low ctDNA levels. But in majority of the times, as I'm showing here, ctDNA resulted in identification of multiple actionable alterations similar to what we have with our tissue sequencing. Here on the left, I show you the MSK impact results. On the right-hand side, MSK access results. And as you can see, more than 60% of breast cancers, ER-positive breast cancers, have actionable alterations. Slightly different alterations are identified in ctDNA versus tissue, but overall ctDNA performing really well in identifying many of the mechanisms of resistance and also actionable alterations in breast cancer. So if we just look at this schematically on how this evolves, the patients can have multiple subclones or majority of times, one or two major subclones that are resistant to therapy. And what we have been doing so far, we wait until the patient has a radiographic or clinical progression, At the time of radiographic progression, we offer the patients liquid biopsy, we identify the mechanisms of resistance, and then based on that, we act. And the main example of this is obviously the Emerald trial. The patients received mainly first-line CDK4/6 plus AI. They're included and they're monitored if the patients developed ESR1 mutations as the second line or later they were randomized to receive a third elacestrant versus not. And as you know, this resulted in approval of elacestrant single agent, significant improvement in compared to the fulvestrant arm. And that was mainly in the patients who had better progression-free survival on the first-line CDK4/6 inhibitor plus ET, more than 12 months, meaning that there were no other major mechanisms of resistance to endocrine therapy or CDK4/6 inhibitors in this group of patients. So these are mainly endocrine-sensitive tumors that have ESR1 mutations. Addressing the ESR1 mutation resulted in a major improvement of the outcomes in these patients. But can we do better? Can we intercept earlier? Can we identify the actionable alterations before the patient has radiographic and clinical progression? And the main hypothesis here is that can we decrease the clonal diversity of the tumor early on? So there is a subclone that resulted in resistance. For example, in this setting, it was ESR1 mutation. Can we, before this subclone becomes a major subclone, dominant subclone, and goes through the clonal sweep and develops more diversity within that subclone, if we intercept early, can we improve the outcomes of the patients? And these are the type of clinical trials that can be designed in this space. The patients go on standard of care, being routinely monitored with liquid biopsy. At the time of identification of actionable mechanism of resistance, the patients will be randomized to escalated care versus continued standard of care. These patients do not have progression of disease clinically, and then follow the patients for PFS1, PFS2, so on and so forth. And the main example of this, obviously, was the study that was done by Francois Clement-Bidard, PADO-1 trial that showed in the patients who receive AI plus palbociclib, at the time of identifying a ESR1 mutation with a condition of rising ESR1 mutation variant allele frequency on the subsequent test, if those patients were randomized to continue AI plus palbociclib versus fulvestrant versus palbociclib, there was a significant improvement in the PFS1 and also PFS2. That was the basis for the SERENO-6 study that was presented at ASCO this year and published. In this study, patients after 6 months of endocrine therapy plus CDK4/6 inhibitor, AI plus CDK4/6 inhibitors, they were randomized. They were started to have monitoring of the ctDNA using the Garden assay, and if the patients were identified to have ESR1 mutations, they were randomized to camizestrant versus continuing the therapy. It was a double-blinded placebo-controlled study. Not all the patients were included at 6 months. Some of the patients were included at later time, and the study didn't require certain level of ESR1 mutations or riding ESR1 mutations. Simply identifying the ESR1 mutation was enough for the patients to be included in the study. And as you know, the study was a significant study, positive study on the PFS1. So the patients who were switched to camizestrant versus the ones that continued with AI, camizestrant resulted in a significant improvement with the adjusted hazard ratio of 0.44 and a median PFS of 16 months versus 9 months from the time of randomization. This was consistent across all the subgroups. And I think more importantly, the PFS2 part of this study, which is important for us, is still pending. There was a trend towards improvement, and I expect that to be a positive one. They didn't have enough events. So hopefully in the subsequent conferences, we see the results of the updated results with the PFS2. But what is important, in my opinion, is this particular analysis of deterioration of the quality of life. So time to clinical deterioration significantly also improved with the switch to camizestrant. This is again, for us who treat patients with metastatic breast cancer, it is important to keep the quality of life of the patients, especially for these ER-positive patients, keeping them on the first, second-line treatment with the minimal toxicity before switching them to chemotherapy or other targeted therapies that they have more side effects. And I think it was very significant, in my opinion, that this switch resulted not only in the PFS1 improvement and potentially PFS2 improvement, but also delayed the decline in the quality of life of the patients. The second half of the talk, I will focus on another aspect of ctDNA monitoring in breast cancer. So there are multiple studies now ongoing, identifying other mechanisms of resistance, actionable alterations, so on and so forth. But ctDNA itself is a very, very good biomarker to identify the disease burden. The amount of disease overall is very much associated with the total levels of ctDNA in the blood. So can we monitor the ctDNA routinely and identify the patterns of response and resistance to the treatment and identify the resistance much earlier and progression of disease much earlier than we would have done in this setting? And can improvement of the ctDNA limits of detection using the assays that we have developed for MRD detection in early stage breast cancer potentially even improve our understanding and the way that we can monitor the disease with much more accuracy in metastatic breast cancer? So I'm going to show you some of the data in this setting. So it's the data that I just presented also at ASCO on the serial monitoring. I just presented the first part of it that was looking at ctDNA monitoring using a bespoke assay. These are tumor-informed bespoke assays. So 16 mutations were identified based on the tumor. The patients were monitored with that. This type of monitoring provides a much lower threshold of detection than what we do with the panel testing. There is not much of an error and noise from clonal inadequacies or from sequencing noise as we just look at the small number of mutations, mainly clonal mutations. And that also allows us to have a very consistent assessment of ctDNA burden across the board as we monitor these patients serially. So we analyzed the patients with two and dichotomized them in two different settings. The patients who had early favorable response in ctDNA levels. Those are the patients who had a decline, not detectable ctDNA, or decline in ctDNA, or ctDNA was not detectable anyhow at baseline, versus the ones that had an increase in ctDNA on the first assessment within 2 to 6 weeks from the start of treatment. And this was significantly associated. Favorable outcomes were significantly associated with better outcomes in this setting. This was across after adjustment for multiple covariates, treatment type, receptor subtype, so on and so forth, it still remained highly significant. When we looked at different breast cancer subtypes, ER positive, HER2 positive, and triple negative, again, consistently we saw the same pattern. This was much more pronounced, I should say, in triple negative and HER2 positive disease. In this particular analysis, this was a real-world data analysis using the data that was available. And then when we looked at the ER positive patients, time to treatment change, again, with the CDK4/6 inhibitors and chemotherapy, the patients who had unfavorable ctDNA dynamics had a worse outcome in this setting as well. And I think this was an important part of it as well when we look at the ADCs in this setting, and these are the treatments that we often use in the metastatic setting early on, and some of them have major toxicities, so on and so forth. We would like to know if we need to continue with these treatments or not. And we can see here that the patients with the favorable outcomes on ADCs, favorable ctDNA dynamics, they had a much better outcomes on ADCs as well. So the question is ctDNA a good correlate for the disease burden? If we compare it to the state-of-the-art imaging, which is in metastatic setting, PET scans, are they correlated, and how good is the correlation? So we looked at the subset of these patients at MSK, more than 70 patients at MSK. And then we went for the patients who had the concurrent PET scan and the ctDNA analysis. And overall, as you can see, based on the assessment, metabolic tumor volume or tumor lesion glycolysis, that includes also the FDG avidity of each lesion into the analysis, there was a significant correlation between ctDNA levels on the y-axis and the PET scan determined volume of disease on the x-axis. And there were significant discordancies. There was a group of patients who had very high ctDNA levels but didn't have anything on imaging. And on the other hand, there were some patients who had disease on imaging but didn't have much of a ctDNA detectable. And we looked at these patients, and the ones that they were discordant with high ctDNA, often this was delayed. It was a lead time. The patients in the subsequent imaging had progression. Some of them had delayed clearance of ctDNA, especially after radiation therapy. ctDNA levels can remain high due to tumor kill and prolonged tumor kill because of the radiation, while imaging can show some shrinkage of the disease much earlier. On the other hand, a majority of the cases that when ctDNA was not detectable, but imaging showed progression or showed significant amount of disease, seemed like, this was early molecular response. And in very rare cases, also the patient had true disease, but was not below the threshold of ctDNA detection, mostly skin luminal disease involving the skin. And there were also some evidence of pseudoprogression, something that we haven't seen with some of our therapies. I'm going to show you some of the examples of this. So this is a patient with concordant disease. This is a patient who received a fifth-line treatment with paclitaxel. As you can see here on imaging, the patient had progression of disease on the PET scan, and concurrently, ctDNA also showed a significant increase. Earlier, as you can see here, early ctDNA levels also showed the progression. And the patient went on a first-in-human dose escalation phase 1 clinical trial. And as you can see, the patient had a fantastic response with a significant decline after only one cycle of treatment in ctDNA levels that resulted in a response on the imaging as well. What was, I think, striking for this patient, it's not on this image, is that this patient on the first scan in the March of 25, she seemed to have some lung findings that our radiologists were concerned about lymphangitic spread versus interstitial lung disease on this experimental therapy. And based on these ctDNA outcomes and results, we decided that this is most likely ILD and not lymphangitic spread. The patient stays on this study, received a short course of steroids, and has been the best responder on that phase 1 clinical trial. She's still on that phase 1 clinical trial. This is a patient who received, with a ER positive BRCA carrier, optimally treated in early stage disease, developed metastatic disease with a solitary brain mets and also a solitary liver met. Brain met was resected and radiated. She started first line olaparib. She was treated with the adjuvant ribociclib, and she had a fantastic response, complete response. ctDNA monitoring was started. The patient had some increase in ctDNA levels. PET scan was negative. But because of the ctDNA level, that prompted us to get an MRI of the liver, showed a very small lesion at the site that she had the disease before. And we did a SBRT of that particular lesion. I show you the planning here. And that resulted in the clearance of ctDNA, and the patients remained ctDNA clear for a year on olaparib after this radiation. She had some increase in ctDNA level. Imaging showed bulky leptomeningeal disease with no evidence of systemic disease. The patient was treated optimally with proton CSI. She continues to have a significant amount of disease based on ctDNA and CTCs on CSF. So we started IT, intrathecal topotecan, followed by TDXT. That resulted in the clearance of ctDNA and CTCs in the CSF and clearance of the ctDNA in the blood as well. The patient actually remained NED for almost a year after this. Unfortunately, she died of TDXT ILD toxicity. But nevertheless, this is a good example that ctDNA can be monitored, that now we have a clinical trial at MSK. Patients with oligoprogression and oligo-persistent disease will be are being radiated, and then we monitor the ctDNA afterward. The plan is in the next phase of the trial to escalate and de-escalate systemic therapy based on the dynamics of the ctDNA. At this stage, the patients are just being followed with progression-free survival. My colleague Amy Zhu is doing this study. But some discordant cases. So this is a patient with triple-negative breast cancer who received first-line TDXT. And as you can see on the first scan, there was an unequivocal progression of disease based on PET and also the CT scan. But what was striking in this case was a significant decline in the ctDNA level that prompted us to think that this is potentially a pseudo-progression. We had a biopsy of this particular lesion, and we knew that this was metastatic breast cancer, triple negative, PD-L1 negative. Based on these results, the patient decided and we recommended to continue with TDXD. The patient actually on the subsequent exam had a complete response based on PET scan, and also the lesion resolved. ctDNA became undetectable. She developed interstitial lung disease December of last year. At that point, we stopped the TDXD, and she's been monitored with ctDNA and imaging system off treatment. This is a patient with very aggressive triple negative breast cancer. And another patient with discordant, this is a patient who was receiving sacituzumab as a fifth line. She had a significant incline in the ctDNA levels, but the PET scan didn't show much disease. There was some bony disease, but couldn't explain this amount of increase in ctDNA levels. That prompted us to get an MRI of the liver, and as you can see, there was a lot of disease, miliary pattern disease across the liver. The patient received a taxane and later on capecitabine, and as you can see, that resulted in the clearance of ctDNA, significant decrease in ctDNA, and improvement based on imaging. She later on started to develop progression of disease, as you can see here. Imaging based on MRI, not the PET scan, MRI, and also the ctDNA both showed increase in the ctDNA, in progression of disease, and she started a new therapy at this point. So we are now trying to understand this better, do this in a prospective manner, in a randomized manner, to see if they actually ctDNA monitoring. And we're not saying that we can completely get rid of the imaging. De-escalation of imaging based on, and also emphasizing the ctDNA monitoring in this space can be as effective as our standard of care radiographic monitoring in these patients. So this clinical trial is being designed and going through the final steps, and I hope to have this open by the end of the year at MSK to start actually answering this question: can prospective monitoring improve the outcomes based on ctDNA or not, or at least as good as radiographic monitoring without much of a burden of imaging, without and also with the convenience of having someone go to the patient's home, get a blood draw, so on and so forth, something that we routinely do in the United States. The last couple of minutes, I'm just going to talk about using ultra-sensitive assays. These are the next generation MRD assays that can push the limits of detection to 1 part per million or lower. These are ultra-sensitive assays. Can we utilize them, and do they change any of the outcomes when we start using them in this setting? And can we identify the patients better? And we just presented some of our data as well. These are 57 patients receiving CDK4/6 inhibitors, and they're monitored with the ctDNA ultra-sensitive assay. And we showed that ctDNA levels are highly predictive of progression and also response, and ctDNA was detectable in all the patients. But most importantly, what I would like to highlight is the fact that we looked at 6 patients who had a complete response based on imaging. And in some patients, ctDNA levels were extremely low, 1 part per million, 1 to 10 part per million, 10 part million, so on and so forth. But a group of patients with a complete response had undetectable ctDNA levels, telling us that there is a possibility that there is a group of patients with ultra-sensitive assays do not have ctDNA, might have been even cured with our treatments. These are the patients that we have. They stay on these treatments for a very, very long time. All of these patients had sustained CRs for at least 2 years when they started, when we did this analysis. So again, some group of patients had very small amount of ctDNA, but complete response by imaging, but some patients had undetectable ctDNA. We are looking more into this to see if we can predict this and identify these patients with outstanding responses better. And also, we are trying to answer one question here: can we eradicate disease using de-escalation, escalation approaches that we have been using in early stage breast cancer, utilizing these ultra-sensitive ctDNA assays, and also next generation therapeutics that we have tried to eradicate the disease in the metastatic breast cancer as well. I'm happy to report this study hopefully will be open next month at MSK, going through the final approvals in the IRB. This is called Horizon Breast. This is our curative intent study in the HER2-positive metastatic breast cancer in the patients with de novo metastatic disease. We put together some paradigms and some principles for the study using sequential anti-HER2 therapies, utilizing local therapies, both with surgery and radiation, similar to what we do in the neoadjuvant setting, significant emphasis on the CNS monitoring and prophylaxis, and also having molecular complete response based on ultrasensitive assay as our outcome. And try to see if we can actually improve the outcomes of our patients. So I'm just showing a very simplified schematics of this study. The study is actually much more complicated, but we borrowed from our colleagues in the liquid tumors and hematologic malignancies. They cure very aggressive cancers using their induction, consolidation, maintenance type of approach. So the patients are being induced with our best treatments for HER2-positive breast cancer, THP, TDXD, so on and so forth, TDM1. And the patients will be going to salvage induction if the patients cannot completely eradicate the ctDNA. So if the patient has a complete response on imaging but still have molecular evidence of disease, this patient will be escalated to salvage induction. The goal here is to achieve a molecular complete response and also complete response by imaging. We also perform surgery and local therapy on these patients as well. The patients then go on a consolidation therapy with the CNS penetrating regimen, try to eradicate the disease. We also monitor the patients with CSF analysis serially on this study as well. And then after that, the goal is to put the patients on no treatment after we achieve all of these goals and just monitor the patients with the outcome of molecular complete response, maintaining the molecular complete response and complete response for at least a year, and also the secondary endpoint of progression-free survival from the time the patient goes on the study. So this is a proof of concept. We try to show that curative intent therapies are possible in metastatic breast cancer, going after our HER2-positive patients, but hopefully with the data that I showed also in CDK4/6 treatment, we can potentially expand these type of studies to other subtypes as well. So in conclusion, ctDNA monitoring and liquid biopsy is here for us to be utilized. We use them routinely to identify actionable alterations at the time of clinical progression. And it has advantages over tumor sequencing, but does not completely replace the tumor sequencing, as some of the alterations are better identified in tumor sequencing. And I think there is also a potential for serial monitoring of ctDNA. We see if FDA approves camizestrant based on SERENA-6. And if that happens, obviously ESR1 mutation monitoring will become part of our practice. If not, I think, there's still potential for ctDNA monitoring using this type of approaches for identifying and monitoring the disease burden and also prediction of outcomes, and trying to and designing the next generation clinical trials in trying to improve the outcomes of our patients. So with that, I would like to thank all of my colleagues at MSK and outside, our patients and their families for participation in our studies, our patient advocates, and also our funding sources. Thank you.
Muchas gracias, doctor Razavi. Le pedimos al doctor García Gerardi, por favor, que le pueda realizar una consulta. Está muteado, doctor.
Está muteado, doctor García.
Perdón. Muchas gracias, doctor Razavi, por su excelente presentación, lo cual nos propone, nos desafía a los oncólogos clínicos a pensar a los pacientes en una forma diferente. La pregunta muy concreta, se me ocurren 1000 preguntas para hacerle, pero voy a una sola concreta en honor al tiempo. En aquellos pacientes que usted cambió un tratamiento porque aumentó el ctDNA y observa que ese ctDNA se mantiene estable, no sube, no baja con la terapia nueva que instauró, ¿usted esto lo homologa a una estabilidad de enfermedad como lo hacemos habitualmente? ¿Qué tiempo le da al tratamiento para ver si disminuye el ctDNA y debe cambiar o no nuevamente el tratamiento?
Oh, that's a very good treatment. So if I understand the question correctly, you're asking how long does it change for ctDNA to respond on the subsequent therapy for the patients who do not respond if we change our treatment based on ctDNA levels? So it very much depends on the type of treatment. With some treatments, ctDNA levels declined very quickly. In targeted therapies and some of our other treatments decline very significantly. Within days, actually, on some of these CDK4/6 inhibitors, the patients receive CDK4/6 inhibitors, ctDNA within 7 days or 14 days, as Nick Turner also showed in the analysis of the PALOMA-3 on day 15. In our analysis, even at day 7, we can see a significant decline. Then there are some treatments, actually, we are learning about this, like some of our ADCs with a very long half-life. It takes much longer for ctDNA to decline. And actually, if you do not do the ctDNA analysis at the right timing, meaning that we collect the ctDNA mid-cycle, we may actually see an artificial increase in ctDNA levels. For example, T-DXd has a half-life of 8 days to 10 days. So if we collect the ctDNA 1 week or 10 days after we start T-DXd on a patient with significant burden of disease, it's actually in the middle of the tumor kill when there are a lot of ctDNA is being shed into the bloodstream that artificially shows significant increase in the ctDNA levels. What we learned is that, we can take advantage of it. It's actually, this increase is a good sign, but if by the next cycle, when the ctDNA is completely cleared, and ctDNA has a very short half-life of minutes to hours. So by the next half-life, cycle 2 day 1, cycle 3 day 1, if we see a decline, that's a very good sign. So it very much depends on treatment. On radiation therapy, our experience, the ctDNA clearance can take weeks. And actually, ctDNA can peak up to 4-6 weeks, something that we knew that ctDNA, the radiation has a delayed effect, and that now we are showing it very clearly on ctDNA, that ctDNA actually peaks. The more aggressive the tumor, the higher the turnover of the cancer, the higher the peak, and the sooner the peak, earlier the peak, and the decline with radiation therapy. For tumors that are slower growing, that peak comes a little bit later. So we need to consider all of those factors when we are trying to understand this. So that's one of the things that we're going to study on that ctDNA monitoring study. That's an excellent question.
Thank you very much, Dr. Rasavi, and thank you, Dr. Garcia Gerardi.
Gracias.
We need to continue with the program. Thank you for your time.
Thank you for having me.
Cari,
Continuamos con la próxima conferencia, que es resultados a 5 años del ensayo inaugural sobre la eliminación de la cirugía mamaria tras la terapia sistémica neoadyuvante, los próximos pasos. La presentación estará a cargo del doctor Henry Curer, que es del Departamento de Oncología Quirúrgica Mamaria del MD Anderson de Houston, Texas, en Estados Unidos, y el moderador va a ser el doctor Rafael Cáliz. Dejo de compartir para dar paso al doctor Curer.
Good morning, everybody. Can you hear me?
Yes.
All right. I'm trying to switch the display settings so you can see it better. Let's see. How is that? So this morning, I'm going to be speaking to you about the 5-year outcomes of our inaugural clinical trial for eliminating breast surgery for invasive breast cancer after neoadjuvant systemic therapy. I think we have to look at this in perspective, taking a look at our axillary surgery de-escalation over many decades, as you can see, in the early 2000s with us developing sentinel lymph node biopsy, and moving forward even in node positive breast cancer. We designed and implemented targeted axillary dissection where we could even lessen or decrease the amount of surgery in the axilla for node positive breast cancer after neoadjuvant systemic therapy. Now, of course, we're in the sound era and encema era where we are selectively eliminating axillary surgery and sentinel node biopsy, and with the URBreast trial, URBreast 1, even eliminating axillary surgery based on the breast pathologic complete response. So the question is really, in 2025, today, we've had a logical de-escalation in breast surgery, and we've eliminated the need for axillary surgery. Why not do this in the breast itself? So we've known for so long that there are these patients with an exceptional response to chemotherapy. This patient from a long time ago had an estrogen receptor negative tumor, and she had a complete pathologic response with only 4 cycles of chemotherapy. So we've known about these patients, and now in the subtype and therapy era, we know that at least of all comers in early stage breast cancer with triple negative and HER2 positive breast cancers, that at least half will no longer have any residual invasive breast cancer in the breast after our surgery. We know that this is associated with a increase in disease-free and overall survival when there's a pathologic complete response, and the local recurrence rates in these subtypes are extremely significantly lower when there's a PCR. So why even consider eliminating breast, and I'll show you axillary surgery, is because 60% of the time in screen detective triple negative and HER2 positive breast cancer, we have a complete pathologic response. And that is a huge number of patients, as you can imagine, worldwide. And although lumpectomy is considered easy, and we can do the surgery with lumpectomy and axillary sentinel node biopsy in an hour and a half or an hour, there are significant surgical and anesthetic morbidity. And on the patient's perspective, this can be up to 30%, and sometimes it's multiple different issues: cosmetic outcomes, infections, paresthesia, reoperation, lymphedema, psychological impacts adversely. Just frankly, if there's no residual disease, we had to figure out a way to identify those patients. Now, this concept is old, with the medical oncologists from these early landmark studies saying, well, we can't palpate anything, let's just give radiation. The results were generally very, very high local recurrence rates. And this, of course, was due to the fact that they were not using imaging to select the patients, and it was prior to our understanding of response based on subtype. Another issue is our best modality is breast MRI, but even in breast MRI, a radiologic complete response will occur in only about 20% of our patients, but 50 to 60% will have an actual PCR. So it overestimates as well as sometimes underestimated. So our hypothesis was that we could accurately identify the patients with the pathologic complete response by selecting patients based on imaging response and then biopsy in super selected patients. For those in the audience, we use a vacuum-assisted core biopsy. 1 stick is made in the prior tumor bed, which you can see in our first patient on the left. And the design of this trial allowed for 98% of the tumor bed to be sampled histologically. Now you say, are you removing a lot of tissue? No. If we remove 12 portions of tissue, we can accurately identify the pathologic response with a false negative rate of about less than 5% for these patients. So that was our foundational trials to say, could we even do this? I remind myself here that it's very highly dependent on our breast imaging and our pathologist, not only in selection of the patients with unicentric breast cancers, but to have accurate assessment, we need to have the imaging less than 2 centimeters to accurately, with the modeling, to accurately assess the tumor bed. And critical amongst this, as we develop these no surgery treatments in the future, these is dependent on the best pathologist. It is not just a few slides that they make of that biopsy. They entirely submit all of that tissue as not to miss any residual breast cancer, which would potentially impact recurrence and selection of systemic therapies. In our initial trial was only 40 patients. We used a 9-gauge biopsy technique. Of course, the PCR rates were about 50%. The size of the tumors, as you can see, were small, just like screen detected. And we removed 12 portions of tissue on median for this. I say that we cannot have residual disease or in situ disease, that is invasive or in situ, because we don't want to leave a nidus for recurrence. This is the foundational study results. Key here is that it could accurately, the biopsy itself, remember all these patients had surgery. We're just verifying our modeling and the technique, an accuracy of 98%, false negative rate of 5%, small study. Keep in mind the false negative events occurred in 2 patients where only 6 and 4 core samples were removed, and we learned that for the definitive trial of no surgery that we needed to sample the tumor bed accurately. This has been found to be the case in the prospective NRG trial as well. So what I want to say here, a really important point is, we don't want to miss residual disease, but we fool ourselves by saying, well, surgery will have a false negative rate of 0 for detection of residual disease. It is not true. When we have a negative margin from standard lumpectomy, about 10 to 20% of the time, if you go back, you're going to find residual disease. Our hypothesis and what we're affirming to you is that because this is super image guided with the biopsy, the needle biopsy, that the pathologists very carefully go through all of the tissue, we believe that this is even more accurate in detecting residual disease than our standard surgery. This is the multi-center trial, which I'll tell you the results for. Women had to be over 40, unicentric triple negative or HER2 breast cancer, less than 5 centimeters at the beginning, and no more than 4 abnormal nodes. And each node that was abnormal had to be proven to be malignant or not. Patients received standard HER2 directed and triple negative breast cancer directed systemic therapies. Again, I make a strong point that on imaging, abnormalities had to be less than 2 centimeters, calcifications, enhancement, mass, density, because otherwise we could not accurately identify residual disease. This shows the exclusion criteria. The trial has been published in Lancet Oncology and more recently in JAMA Oncology. And this just shows the trial schema. Obviously, patients with residual disease receive standard surgery. Those patients on biopsy did not receive any breast surgery if there was a pathologic complete response. We followed these patients very carefully, looking as the primary endpoint of ipsilateral breast tumor recurrence. We followed them at 6-month intervals up to 5 years, and now we have consented most of the patients to follow for 10 years. Secondary endpoints are listed here. There were a total 50 patients. I want to say that the average tumor size was extremely low size, 2.3 centimeters. The mean number of tissue samples removed on biopsy was 15. And I want to say that on the initial trial we performed, there was 100% concordance. If the patient had a PCR, we did perform in the node-positive breast cancers a targeted dissection with, on average, 1.5 lymph nodes removed, and there was 100% kill in those lymph nodes as well. This slide shows the primary outcome of the clinical trial. The results demonstrate that this new approach, the paradigm for eliminating breast cancer surgery after neoadjuvant systemic therapy, is both safe and effective. We say this because there were no local recurrences with 100% ipsilateral breast tumor recurrence-free survival and 100% overall survival and disease-free survival at a median follow-up of 5 years. As you can see, demonstrated here, this was not a fluke. These patients were extremely selected based on very stringent criteria. There was standardization of the biopsy and standardization of the histologic evaluation. These results show that for selective patients, this will likely be a future approach, particularly as we develop better and better systemic therapies. The PCR rates in this trial were, as you see here, overall 62%. We thought that our hypothesis was that surveillance would be very easy for these patients because there wasn't much disruption with the surgery. First of all, we had to figure out, well, if we did a standard lumpectomy in the United States, how often on breast follow-up imaging will the radiologist recommend a biopsy? So at 10 years, about 23% of cases, just standard surgery, would receive a biopsy. We didn't have that information before we looked at these over 100,000 patients in the United States. So our hypothesis was that it would be easier to follow these patients. However, we found that at the 5-year interval, 35% of the patients were recommended for biopsy during their follow-up. All biopsies, of course, were benign and concorded with the imaging. I think that the radiologists, understandably, as this is a new field, were being extremely cautious and wanted to ensure that they were not missing. They initially said, well, the patient didn't have therapy. Well, that is not true. They had very effective therapy. They had very effective systemic therapy and radiotherapy. And we also demonstrated no residual disease, of course, with imaging biopsy. So I think in the future, this is an area ripe for further research. Again, well, what are these how did the patients tolerate this procedure? Were they nervous that they were going to have a recurrence without the breast surgery? We looked at patient-reported outcomes with validated measures, as you can see here. And essentially at 5 years, over time, the decision to forego breast surgery increased significantly. There was a slight difference between the breasts, considering one breast received radiotherapy, and there was a high quality of life at baseline, which further increased over time. So the patients are doing well with this approach. It is a new paradigm, and what we need to really ensure is safety and more clinical trials. I can tell you when we first started talking about this in 10 years ago with surgeons, they're saying, well, why skip the surgery? We have oncoplastic, patients like the surgery. Well, why not skip the radiotherapy if there's a pathologic complete response? And in fact, we agree, and patients are want certain therapies, and this interests the patient as well. We have completed this trial now. My colleague, Melissa Mitchell, in radiation at MD Anderson. Essentially, it's the same clinical trial, except we do standard lumpectomy and or sentinel lymph node biopsy and or targeted dissection. If there's a PCR, the patients skip the radiation. The trial has been completed, and the 2-year results have been submitted by my colleague for publication. So in conclusion, eliminating surgery and radiotherapy selectively for invasive breast cancer after neoadjuvant systemic therapy appears to be safe. However, these are small studies. The field is changing. Better systemic therapies, targeted imaging and biopsy can accurately identify these patients with preliminary data showing that this is effective and safe. Again, the key here is this is not a standard. It is a new paradigm. More studies are being conducted. My colleague here in Korea have their very similar trial, which is accruing well. Han Boyo Lee, multi-center trial of 500 or more patients. That is ongoing now. We have increased the accrual at MD Anderson to 100 patients, and we are more than half done with accrual on the second 50 patients. And I can also tell you there's a lot of interest from our cooperative groups in testing this further across the country. So with that, I'd just like to wrap up, and I'd be glad to take any questions, and thank you for your attention.
Yeah, Dr. Cure, this is Dr. Calix from Brazil. Extraordinary data, obviously. I was just wondering if you could explain to us how you map where to do the 15 core biopsies, or whichever number it is, after you have complete response, radiologic complete response. How do you map it?
So one important point is that, key point here is that mapping isn't necessary because every single patient on the trial had to have only less than 2 centimeters of anything left. So essentially, they circumferentially around the tumor, if you look at a clock, they will just move that needle around to sample small portions of tissue within that 2 center region. About 30% of the cases had no residual imaging. An important point here is that the calcifications and other abnormalities had to be less than 2 centimeters. They also removed the clip that was placed in the tumor. So it's not too complicated because there was very small residuals left to biopsy.
Okay, and the last question is, have you introduced MRD assessment by ctDNA in your second phase of the trial?
Yes, that was a secondary endpoint of the study, and we measured circulating tumor cells and circulating DNA in the MD Anderson patients. And just to mention that circulating tumor cells, a few patients, we found some, and there was no, we successively would measure this, and in none of the patients were there ever more than 1 cell detected, and all of them had cleared. In the ctDNA, now we have to remember this is not the metastatic advanced setting. Among the MD Anderson patients, we found CT, remember, the average is 2.5 centimeters or so, these tumors, most node negative, triple negative HER2 breast cancer. There were only 2 patients where we had at baseline ctDNA. The first patient cleared it completely by 6 months, and another patient had persistence of her ctDNA. Actually, the mutation was P53 in her. And she continues to have it, and she's about 6.5 years out. So we really couldn't correlate it really with PCR because there were no recurrences. So I think it's an area still for ripe for research, and we, in our cooperative group trials, which are being proposed in the United States, that is also one of the secondary endpoints using different methods of measuring minimal residual disease as well.
Okay, thank you so much.
Thank you, Dr. Cueller. Thank you, Dr. Calix. We continue with the program. Thank you very much. Actually, the next presentation will be for Dr. Maurice Nahabedian. He will talk about la evolución de la reconstrucción mamaria autóloga, cambios implementados en los últimos 10 años en nuestra práctica. Es el jefe de la sección de cirugía plástica y Universidad de Georgetown de Washington, Estados Unidos. Y el moderador va a ser el doctor Alberto Rancati y el doctor Eduardo González. Dr. Maurice, you want to start with your presentation?
Yes, I think it's been recorded, so if they can just show the recording, then I'll be available as well for questions and answers.
Ok,
Por favor,
podemos
podrán
lanzar la charla del doctor Maurice.
¿Podemos compartir, por favor, la presentación?
Y Karina, ya la
Doctor.
compartimos.
Okay, doctor, we will share now your presentation, and when it's finished, we have time for some question with Dr. Rancati.
Perfect.
Probably the presentation is very, very important, so we need to wait for that. Cari, mientras tanto, ¿querés compartir cómo es el tema de los certificados?
Sí, los certificados van a estar disponibles dentro de 15 días posterior a este curso. Así también, como recién hablando con el doctor Farante, nos dijo que, bueno, todas estas presentaciones se están grabando, así que vamos a tener una sorpresa al final la contamos, ahora no.
Okay, okay, now we have.
There we go.
Hello, everybody. My name is Maurice Nahabedian. I'm a plastic surgeon in McLean, Virginia, and I'm very happy to be presenting this morning and afternoon on the evolution of autologous breast reconstruction, specifically on what we've changed in our practice over the past 10 years. I think this will be a very interesting topic. These are my disclosures, Allergan Stryker, and I'm the section editor for Aesthetic Breast Reconstruction with the Aesthetic Surgery Journal. So before I get into the details of specifics, I think it's important just to recognize where I was 10 years ago compared to now. I have a long history in academic medicine, spent 25 years at Johns Hopkins and at Georgetown. Most of what I did there was autologous and prosthetic breast reconstruction, and our focus back in 2015 was really on surgical outcomes and technical success. Let's fast forward now 10 years. I'm now in private practice. I still do quite a bit of breast reconstruction. Probably 60% of what I do is autologous. But interestingly, I think the focus now is on surgical efficiency models and outcomes related to patient experience. I think we've all mastered the technical aspects of microvascular breast reconstruction. Now it's really related to efficiency and patient-related outcomes. So how can we improve the patient experience? So how has this changed over the last 10 years? Well, I can tell you that we now have adopted a two-team approach to all of our microvascular cases, and I'll go into some of the detail. We really have focused on post-operative comfort. We do ultrasound-guided transverse abdominis plane blocks using long-acting local anesthetics. We are very interested in DVT prophylaxis, so we do that routinely, whereas it didn't used to be a routine. We really have adopted the early recovery after surgery protocols to reduce narcotic use, and I think these have been very effective. We use fluorescent angiography routinely now on these cases for a variety of indications, and I'll show you exactly how we use those. Back in the day, we used to always have a skin paddle on the flap so we could monitor it, but now we've gotten very sophisticated with how we monitor flaps. So we actually bury all of our flaps, so there is no skin paddle if we've done a nipple-sparing mastectomy, and this is actually good because it reduces the number of future operations. The other cool thing that we're doing is we're starting to reinnervate the flaps and the nipple-areolar complex. And finally, one of the big kind of hindrances with abdominal-based free flaps has been the incidence of a bulge. So now we're using prophylactic mesh reinforcement of the anterior abdominal wall, and I'll get into the details on that as well. So in terms of improving deep flap efficiencies, using co-surgeons doing microvascular is now the new norm. And this was a study that was really done out of University of Texas Southwestern by Nick Haddock and his team. And they looked at various times And they basically found that by having a co-surgeon, that is somebody else who is optimally trained in microvascular surgery, you can reduce operative times, length of stay, and complications. And when you contrast that to single surgeon reconstructions, operating room times were quite a bit longer. And you can see there 678 minutes with a single surgeon versus 485 minutes with a co-surgeon. And I can tell you, we've gone even much less. It's routine for us to do a bilateral deep flap in 5 hours, which would be about 300 minutes. So the co-surgeon model has really increased operative efficiency. Pain management, historically, before ERAS, we tried all kinds of things. We had indwelling catheters, we had pulsed electromagnetic fields. There were all these things that were being introduced to try to improve the patient experience. We would use Marcaine and lidocaine locally, although we didn't use it routinely. Most of the time, we just relied on intravenous and oral narcotics because 10, 20 years ago, that's what was commonly done for postoperative pain management. Now we've really changed. We have adopted these ERAS protocols. We use liposomal bupivacaine for all mastectomies and all free flap breast reconstructions. So not just abdominal flaps, but gluteal flaps, thigh flaps. We use ultrasound to target exactly where we inject. So with our TAP blocks, we're now injecting between the transverse abdominis and the internal oblique muscles. And we give oral antibiotic or oral analgesics upon discharge, but patients are not having to take these as regularly as they used to, and they were able to get off them very quickly. So ERAS protocols have really, really been helpful. The multimodal aspects of how we manage the pain after any of these abdominal wall reconstructions is variable, and there's a whole protocol that's listed. We definitely use TAP blocks, as mentioned. Postoperatively, if patients are in severe pain, we give them Dilaudid. Again, this is uncommon, but that's what's typically ordered. We use gabapentin, we use Valium, we will use oxycodone only as needed. There are some patients who don't even take an oxycodone. And after 2 days or upon discharge, patients can take Motrin or other non-steroidals as needed. And this is just basically an illustration showing where we do our TAP blocks between the transverse abdominis muscle C and the internal oblique muscle B, because that's where the nerves are on the abdominal wall. We also will inject around the breast, and we can do intercostal blocks to block the various nerves, and then we can do a soft tissue block superficially, which also is very useful. And this is just basically seeing an ultrasound live in action with the catheter going right into the plane between the transverse abdominis muscle and the internal oblique. And this is one of our PAs who's really mastered this technique. And we actually use PAs in our practice routinely, and they are incredibly helpful. They're essentially like chief residents on our service. They can operate. These PAs that we have are really superb. Anyway, flap monitoring. So in the old days, we would always, and this was also when we were doing a lot of skin-sparing mastectomies, we would always leave a skin paddle. And some of the downsides of a skin paddle is sometimes we would have to revise them. Sometimes the skin paddle, if it was where the nipple was, would flatten the apex of the breast, and they would not really be happy with that. So we would look at the color, and we'd get a Doppler, and we'd do assessments of capillary refill. And sometimes with cutaneous oxygen saturation levels, there's all sorts of methods that we could use to monitor the flaps, which were fine. But now, a lot of it is really born out of the fact that we are so successful with these operations, where our success rates are north of 99% now. It's really unusual for us to lose a flap. We can bury our flaps in the setting of nipple-sparing mastectomy, and this was a patient who had had a previous failed device on this side and had some healing problems, but we were able to do bilateral deeps. We buried the deeps. We can monitor the Doppler signal through the skin paddle or through the skin of the mastectomy right over where the Doppler is on the flap. And it's very accurate and it's very good. And it actually saves patients to have another operation for some of these revisions. Fascial closure techniques. Historically, with the deep flaps, we would always do a 2-layer fascial closure, and sometimes we would do fascial plication if it was beneficial, but because we're really taking so little of the anterior rectus sheath, just a 2-layer closure was possible. The problem is we would still see bulges. In bilateral patients, sometimes 6 to 8% of patients would get a bulge. In a unilateral case, it might be 4 or 5%. In cases where we had to excise the fascia, like if we did a muscle-sparing free tram, sometimes we would use a mesh. It could be a biologic mesh, it could be a synthetic mesh. And on some patients, occasionally we would put an onlay mesh. But despite all of these, we would still get abdominal bulges or hernias. So really the question then became, does the routine use of a probe reduce the risk of a postoperative bulge or hernia? And a lot of this was born out of this study that came out of North Carolina with Nick Klaban and his group. And this was basically a 5-year study from 2010 to 14 using poly-4-hydroxybutyrate mesh placed as an onlay prophylactically. And basically, they compared these onlay meshes to a cohort of patients who did not require mesh. And the bulge rate with the mesh cohort was 0, whereas the bulge rate with the no mesh group was 5%, which is typically what we would normally see. And that was statistically significant. It really made a difference in the bilateral cases. In the unilateral cases, it didn't bear out statistical significance, but it did approach statistical significance. But for bilateral cases, it was clearly beneficial. So I just wanted to basically show how I do this. So typically, after we harvest the muscle or the deep flap, there's going to be a gap in the muscle. Sometimes we have to take a little segment, sometimes we don't, but we always just put that muscle back together. That way, intra-abdominal pressure won't cause any muscle separation. So that's the first thing we do. And then we'll go ahead and we'll close the anterior rectus sheath, and we usually do this in a 2-layer fashion. We'll use basically a zeroproline in a figure of 8 fashion initially to get the fascial layer closed. And this is going to be a bilateral deep flap. So one side is harvested, the other side's still there. We're doing micro while our PAs are working. Another way we are able to increase efficiency by speeding up the operation. Here we do a running closure, and usually this is with a barbed suture like a quill or V-lock or something of that sort, just to further reinforce that closure. And then we'll go ahead and take this P4HB mesh and we'll start sewing it in. And this is, again, all happening while we're doing microsurgery up top because our PAs are able to close this. So we basically interrupt it, and we start on one side of the abdomen. And once we harvest the other flap, we'll go to the other side of the abdomen. So here we basically just harvested the flap, closed the fascia. Now we're placing the mesh over onto the other side, and we can inset it just like we did on the other side. And then once that's all done, and you can see how nice it lays, we'll go ahead and do a running around the periphery, and then we'll put some interrupted quilting sutures to prevent any bowstringing. We can make a little hole, bring out the umbilicus, we'll undermine, we'll plicate superiorly just to improve the overall contour if there's any diastasis. And this actually has been a very successful method of doing this. And this is what it looks like upon closure. We've got primary fascial closure with 2-layer reinforcement with a P4 hydroxybutyrate mesh over the anterior rectus sheath that's sutured in across the entire distance. This is just an example of a patient. She's 54. She's got left breast cancer. She's got a diastasis, although you can't see it here. She's scheduled for muscle-sparing free tram flaps. When we were harvesting the flap, she had this big diastasis. Again, we couldn't see it unless you were actually testing her pre-operations, but certainly on the table we could see it. Harvested muscle, put the muscle back together, did our closure, and initially she had this contour abnormality, so we have to do a lot of plication in the upper pole. You can kind of see the lateral view, the front, the top side view, big contour abnormality. You cannot close the skin looking like this because you'll have a really bad abdominal contour. So we plicate up top, and then we reinforce this with a P4HB mesh. And you can kind of see how effective we were with our plication, because on lateral view, everything is nice and flat now. Here's our mesh in place, kind of a lateral view. Everything looks good. And then, here she is post-op, buried flaps, good Doppler signals throughout. We've gone ahead and closed everything. She's 6 months or 9 months out here at this point, and everything looks pretty good. She's got a flat abdomen. She's got a thicker girth, but there's no abdominal bulge or hernia. Fluorescent SPY angiography. This has been a huge advance for us. Real-time perfusion using ICG, laser light, and we can capture fluorescent images. We're using this portable handheld device now. We used to use this much larger device, but this has really taken over. We don't use the SPY Elite anymore. We use the SPY Fi, which has really been tremendous. We can see cutaneous perforators preoperatively, intraoperatively. You can even use it postoperatively if you wanted to. We can look at the mastectomy skin flaps. We can look at free flaps, pedicled flaps. We can look at anastomoses and see the blood flow going through them. And there is a very good correlation between poor perfusion and tissue necrosis. So this is something we do on virtually every case. So here you can see a patient who's got flaps raised. She's got a deep flap on one side and she's got a muscle sparing on the other. And we can really see how we've got good inflow. And if you wait long enough, you'll actually see outflow. So you'll see the ICG wash out of the flap, and you can kind of see it getting a little bit darker over time. So good inflow, good outflow, which is what we typically want to see. Now, one of my partners really kind of pioneered this approach, looking at outflow over time. So after we've done our initial SPY assessment, we'll wait about 10 minutes or 15 minutes to make sure that all the ICG has gone out of the flap. And this video is not loading very well here, and I apologize for that. But what it basically shows is a very dark flap, meaning that all the ICG has gone out, which is basically confirming that we've got good venous outflow. In terms of skin perfusion, I think it's very important to do as well. This is a patient who had a very aggressive mastectomy, not skin sparing, and didn't even have a lot of undermining. But I didn't think there would be any problem with her cutaneous perfusion. But when we did do our SPY, and I'll kind of fast forward here a little bit, you can kind of see there's this dark zone here in the upper mastectomy skin flap. And, over time, and you can follow this out for 2 minutes, it doesn't really get better. So this is an area that SPY said wasn't very good, but looking at the patient, I thought, well, I think it is good. So I made the mistake of ignoring what SPY told me. We did some quantitative analysis, and sure enough, there was a perfusion mismatch. These lit areas are all well perfused, but this dark area is poorly perfused. This is what it looked like on the table. The lower pole and the upper pole looked exactly the same. Interestingly, 4 days later, this is what it looked like. So again, I think with these devices, the technology is very accurate. And even though it looked okay, it turned out not to be, just as SPY predicted. One of the things we're doing a lot of now is nipple sparing mastectomy, even in very large breasted women who otherwise would not be candidates for nipple sparing. So this is a patient who's had a de-epithelialized inferior dermal flap with the nipple attached. Now, you may think this is a random flap, but it's actually an axial flap based off the intercostal vessels, which have been preserved here. And when you look at this SPY recording here, you can see good inflow all the way up to the nipple areolar complex. And you can see me palpating, and the nipple is nice and white, and the areola is well perfused. And you may think, well, we've got good inflow. But the important thing with these is to make sure that you've got good outflow. So as you chase this over time, you'll see that the ICG is slowly washing out of the flap, telling me that it's got good inflow and it's got good outflow. So this flap did absolutely fine. Looking at microvascular anastomoses, it's remarkable how you can see the inflow coming up into the arterial system, up into the flap. Everything kind of lights up. And then as you wait over time, you'll actually see venous return. So you can actually see the venous blood, and there you see it right there coursing through the vein back in. So this is another way of assessing patent arterial and venous anastomosis. Finally, what we're doing a lot of now is resensation with nerve grafts, and this applies to both prosthetic and autologous reconstruction. And basically, this requires the help of our breast surgeons who, during the mastectomy, will isolate out the T4 or T5 lateral intercostal sensory branch and dissect it. And then we'll basically use a nerve graft, one of these 7-centimeter nerve grafts, to coapt it to the T4 or T5 branch and then take it all the way up to the nipple-areolar complex to try to improve the likelihood of sensory return, because this is something patients are very focused on. So this is basically a dissection of a T4 and T5 nerve. So you can see these nerves coming up through the chest wall, and the location is very predictable. And sometimes you can see medially based nerves, you can see inferiorly based nerves, but they are there. And if you get breast surgeons or plastic surgeons who are skilled at this, you can actually see it pretty well. And then once you get the nerve isolated, you can trim it as needed, or you can leave full length. And then we usually splay the graft. So if you have two nerves, you can hook up two different nerves up into that graft. And then we will go ahead, and this is with a deep flap, we can open the muscle a little bit to create a little pathway for that nerve graft to travel, so it basically doesn't have to travel as far, and you can channel that right up towards the nipple-areolar complex. And then you can basically do another coaptation of that distal nerve graft to the undersurface of the nipple-areolar complex. And we usually use 8/0 or 9/0 sutures here, and then you can just trim it, and then this works very nicely. And this is what it looks like after the fact. So this is 3 months after an implant exchange, and you can actually see the nerve under this ADM going up towards the nipple-areolar complex. And this was a revision I did on a deep flap where we were harvesting some of the lateral excess, and we came across the nerve that was coming from the chest wall and going up through the flap in towards that nipple where we had routed it. So very, very, very good technique. So in conclusion, deep flap reconstruction continues to provide excellent quality of life with increasing numbers every year. ERAS protocols have led to early discharge, especially with TAP blocks. Fluorescent angiography has been very beneficial to assess soft tissues. P4HB mesh has been very safe and effective for abdominal reinforcement. And the effectiveness of resensation, well, we'll see. We're still studying this to see how well it works in the long run. We'll have time for questions that, hopefully we'll be able to answer. So I thank you all for your attention.
Thank you, Maurice. Wonderful presentation, as always. It's a pleasure to see you. I have two questions. One regarding ICG. How often do you use ICG for mapping pre-op to check the position of perforators before mastectomy, and or if you use it just to check perfusion after the mastectomy? And the other one is comparing sensation when you do this microsurgery to graft a nerve, and comparing to, as the case you showed, that you preserve the eye cap where we know you have a nerve there. Have you any information about comparing data?
Yeah, so thanks for your questions, Alberto. As far as the preoperative imaging using ICG, I have done it. When fluorescent angiography first came into our practice, or at least for my practice about 15 years ago, I was doing it more routinely. I was doing it before deep flaps or free tram flaps, even before breast reductions. That way I can kind of see where the blood supply was. I can see where the cutaneous perforators were. With deep flaps, the cutaneous location didn't always correlate with where the perforator was coming through the fascia, because sometimes those perforators travel diagonally. It's not always a straight shot. But with breast reductions, I thought it was very useful because it could help you with pedicle orientation doing a breast reduction. So I think there is a real role for using ICG mapping preoperatively. Again, I probably use it more, though, intraoperatively than any of those other things. As far as the resensation goes, I think we still are on the fence as to how effective it is. I think that some of the technology that you've worked with nerve visualization using ultraviolet light and ICG is going to be very interesting. I think in some patients, I will offer resensation with nerve grafts. It's more the younger patients who are more likely to have successful coaptation and reinnervation. I probably won't do it on radiated patients, patients over 70 years old or diabetics who have a lot of comorbidity, because I think a lot of those patients sometimes develop peripheral neuropathies. So I think it's kind of not very good to expect a return of sensation in a lot of those patients. But new technology, definitely worth trying.
Thank you. Thank you, Maurice. Wonderful to see you. Hope to see you next week.
Yeah, absolutely, Alberto. I'll see you.
Thank you. Thank you, Alberto. Thank you, Maurice. We will continue with the program now. Cari.
Sí, continuamos con la próxima conferencia, que es sobre puntuaciones de riesgo poligénico como herramienta preventiva para el cáncer de mama en la población. Beneficios, riesgos y limitaciones. El jefe de servicio de medicina mamaria, el doctor Mark Robson, del Memorial Kettering Center de Nueva York, y el moderador va a ser el doctor Ernesto Gildesa. Dejo de compartir, les comento que va a haber una presentación en formato video y posteriormente el doctor está conectado, ya aquí va a responder las preguntas.
So good morning or good afternoon. Thank you for the invitation. I am today going to cover the question of polygenic risk scores in risk assessment. This is quite a controversial topic right now, and actually has been for a few years. Reasons that are not entirely clear to me, but I'm going to share with you at least the science that's the background, and if necessary or if we want to, we can have a conversation about the potential utility. So we know that breast cancer risk in the general population essentially follows a normal distribution. So some people are at medium risk, some people are at higher, some people are at lower. This is just intuitively obvious. And it turns out that the relative risk for an individual in the population can range from 0.4 to 2.5, and this doesn't take into account really very high penetrance predispositions. And there are a number of different reasons why an individual may have a different risk than the next one. One is sort of intrinsic factors, such as reproductive risk factors, breastfeeding, and all the kinds of things that we ask when we're doing risk questionnaires. Environmental exposures, radiation is not a particularly common one, but, for instance, hormone replacement therapy, other types of environmental exposures may play a role. And then, of course, where we spend a lot of time talking is the question of inherited factors. So the hereditability of breast cancer is kind of the degree of breast cancer risk that's potentially associated with inherited factors. And the estimate of that is relatively high. It's probably around 0.3. And there are a number of things that can contribute to that. Over the last few decades, there's been a tremendous amount of work devoted to defining the genetic architecture of breast cancer risk. This is the famous histogram, just illustrating the association or the relationship between the relative risk of a particular variant and the frequency of that variant in the population. And the variants with which we are the most familiar are those rare variants of high penetrance that cause autosomal dominant predispositions, and the most well-known, of course, BRCA1 and BRCA2, P53, P10, STK11, those that are syndromic, if you will, genes. Then we have a group of rare variants that are of more moderate penetrance. In other words, these have relative risk from 2 to 5, ATM, check 2, PABI2 is at the upper end of that range. And all of these have a frequency in the general population of less than 1%. In aggregate, of course, somewhere between 5 and 8% of breast cancer may be associated with an alteration in one of these genes. Sometimes in some studies even a little bit higher than that. But on an individual basis, they're quite rare. Now, at the other end of the spectrum, if you will, are common variants that are associated with relatively low risks. So these are single nucleotide polymorphisms that are, by definition, present in greater than 1% of the population. And usually at a particular locus, there are 2 allelic variants, one of which is associated with a higher risk than the other. This is how they're identified. And in breast cancer, there have been a tremendous amount of studies done trying to define what the variants might be. And this is just sort of a summary that was done a number of years ago, illustrating graphically the variants that are associated with hormone receptor-positive disease. And what you can see here is that the allelic frequency, which is along the x-axis, ranges, of course, from anything over 1% to anything less than 99%, with a wide distribution of individual variants in the population. But each individual variant is associated with a relatively low risk, less than 1.1 for most of them. This is for hormone receptor-positive disease. There are a smaller number of them associated with estrogen receptor-negative disease. Again, varying allelic frequencies in the population, greater than 1%, less than 99%, and all of which are associated, or nearly all of which are associated with risks less than 1.2. So individually, these are not particularly useful for risk assessment. However, each of these segregates independently in the population and in an individual, and each of them has an independent effect on breast cancer risk. So what you can do is you can genotype an individual at all of these different loci, determine whether or not they have a higher risk form of the allele in a locus or the lower risk form of the allele in the locus, and then essentially add together the risks from each of these individual loci to come up with a polygenic risk. This is the mathematical equation that illustrates this. The polygenic risk score is the sum, so this is a log additive function, of some individual coefficient, which is the odds ratio associated with the minor allele at a particular locus, times the number of minor variants at that locus. And then each locus can be added together to come up with an aggregate polygenic risk score. The challenge with the polygenic risk scores, and I'll sort of pull this out here right now, is that genotyping is completely accurate. Determining whether or not somebody has 1 or 2 variants in the allele at a particular locus is easy. And by and large, among different populations, the loci that are associated with risk are the same, or at least overlap dramatically. However, in different populations, you may have different coefficients of risk. And so an individual of African ancestry or of West African ancestry may have a very different beta-1 than an individual of, say, Irish ancestry. And of course, if an individual is of admixed ancestry, it becomes even more complicated. So the absolute value of a PRS may actually be a little bit difficult to determine unless you do significant ancestry adjustment. And there's been a lot of that work going on, but so far, moving that into the next step, which we'll talk about later, which is multifactorial models, including a polygenic risk score to come up with an absolute risk, has been a little bit more challenging. All that said, it is very, very clear that when you calculate a polygenic risk score for an individual and then do that across groups of cases and controls, polygenic risk is associated with breast cancer. In other words, the mean polygenic risk score for nearly 34,000 cases was statistically significantly, highly statistically significantly greater than the mean polygenic risk score for a bunch of controls. Now, there is a lot of overlap, but nonetheless, there is an association. The overlap is perhaps not too surprising, since the polygenic risk score itself probably doesn't generate too much of an increase in risk, but it does enough that it can be identified in a large enough group of patients. Now, this is another way of looking at it, which is what is the odds ratio at a given percentile of polygenic risk? And what you can see, of course, is that the higher the percentile of polygenic risk, the higher the risk. And in those few people who actually have polygenic risk scores over the 95th percentile in the given population, their risk is actually greater than that of a moderate penetrance gene. So that small number of individuals with very high polygenic risk scores are at meaningful increased risk. Turns out that polygenic risk is also associated with contralateral breast cancer risk. This is a slightly different way of looking at the numbers, which is that what is the hazard ratio per unit standard deviation? So it essentially flattens this curve into a uniform number that allows you to evaluate polygenic risks for different functions or for different purposes. And what you can see is that as the per standard deviation, hazard ratio goes up by a factor of 0.25. It's greater for hormone receptor positive disease than it is for estrogen receptor negative disease, perhaps because polygenic risk and genome-wide association studies were done in the general population, and therefore there are more individuals with hormone receptor positive disease, and so we've identified more loci. It is also possible, though, that hormone receptor positive disease is more modifiable, if you will, than estrogen receptor negative disease, a topic that perhaps we can come back to a little bit later on. I'd note that the strength of the association between the polygenic risk and overall breast cancer risk decreases with age. So in other words, the genetic influence on risk is greater in younger women than it is in older women. This is particularly the case, if you will, for hormone receptor negative disease, but it applies across the spectrum, which makes sense. As women become older, their breast cancer risk is likely just due to the aggregation of individual genetic insults, and that's less influenced, if you will, by whatever these polygenic variants are doing. Now, this is an interesting point, which is that the polygenic risk score is not responsible for the association between family history and risk. And as a matter of fact, the polygenic risk score is responsible for somewhere between 12 and 14% of the association. And this is because polygenic risk does not segregate as a Mendelian trait. If you think about it, if mom has, 75% of her alleles are high-risk alleles, it's very unlikely that dad will have 75% of the alleles being high-risk alleles. And so in children, the effect of polygenic risk score from the mother will be, if you will, attenuated. Things tend to regress to the mean with subsequent generations. So polygenic risk does not segregate as a metagene, and therefore it only has a fairly modest, if you will, contribution to family history risk. So we still don't understand a lot of hereditability, but we're continuing to work on that. Polygenic risk not only is impactful in the general population, it also is impactful in BRCA mutation carriers. These are data illustrating that the hazard ratio per standard deviation in BRCA1 carriers is 1.14, 1.22 in BRCA2 carriers. You probably don't remember the numbers from the general population, but these are lower. Polygenic risk has less of an impact on risk in BRCA carriers, which is perhaps not surprising because the underlying genetic predisposition is so strong. And also perhaps not surprising is that the estrogen receptor negative BRS has a greater impact on BRCA1 carriers who are predisposed to triple negative disease, and the hormone receptor positive BRS has a greater impact in BRCA2 carriers because, again, BRCA2 carriers are weighted towards hormone receptor positive disease. This is just another way of looking at the same thing. So in BRCA1 carrier who has a low percentile, her breast cancer risk is about 3/4 of that compared to somebody in the middle, and somebody at the highest percentile has 1.5 to 2 times the risk of somebody who is, if you will, a more average degree. So this is statistically significant. Whether or not it's clinically meaningful is something that we can come back to a little bit later on. Now, how do you go about assessing a polygenic risk score? One way that's done is through reporting discriminatory accuracy, and this is kind of a general method for evaluating any kind of test that purports to characterize risk. And the discriminatory accuracy is generally measured by something called a C statistic, which is the chance that a randomly selected case will have a higher polygenic risk score in this case than a randomly selected control. So if the greens are the cases, the blues are the control, what is the chance that if you pick a green and a blue out of a hat, the green will have a higher polygenic risk? And this is essentially equivalent to the area under curve of a zero operating curve if you look at other assessments of test validity. And overall, the statistics are statistically significant. So in women in the general population, the discriminatory accuracy is about 0.62, which is less than that or in the neighborhood of that associated with some of the better empiric risk models. And it is less discriminatory in BRCA carriers, which goes along with the observation that it has less of an impact. Now, discriminatory accuracy is often used as a measure of test validity or test quality, but there's a big problem with it, which is something can be perfectly discriminatory and completely wrong. But here's a situation where the cases and the controls this is a situation where the discriminatory accuracy is essentially 100%, but it's not telling you exactly what the risk is. So this says that the median risk for the cases is here, the median risk for the cases is down there. The discriminatory accuracy is 100%, but discriminatory accuracy is also 100% here. And yet, obviously, the median risks for the cases and controls here are completely different than what you saw on the prior slide. So discriminatory accuracy is useful, but is incomplete. And what we really want to know in the clinic is how well do these things predict absolute risk. Now, you can turn a polygenic risk score into an absolute risk calculation by just simply adjusting, if you will, the known incidence rates of breast cancer in a given population according to polygenic risk. So in other words, you use the risk figures that are calculated, or the risk ratios that are calculated from polygenic risk to adjust it. So here in BRCA, female breast cancer, if you either in BRCA1 on the top, BRCA2 on the bottom, if you have the black line being the average risk, the blue lines are the risk calculations or risk estimates if you adjust that average risk by the polygenic risk. So somebody who is in the 90th percentile may have a lifetime breast cancer risk estimate that's substantially greater than somebody who's in the 10th percentile, and vice versa. This also works, incidentally, for male breast cancer. And perhaps more importantly, it works for people who have alterations in moderate penetrance genes. So depending on what the PRS is, these are now 5-year absolute risk calculations. You can see that there are substantial differences in the 5-year risk calculation for someone who is at a 10th percentile versus a 90th percentile, and that may have a meaningful impact on lifetime breast cancer risk. So there was a study done looking at the estimates for what are the proportion of U.S. women who have a pathogenic variant in a moderate penetrance gene who actually wind up having a less than 20% lifetime risk estimate if you incorporate the polygenic risk. And what we can see here is that, in BRCA1 and BRCA2, because the underlying incidence is so high and the impact is so modest, you're very unlikely to adjust a BRCA1 or a BRCA2 carrier out of what we consider to be the high-risk category. But the same really applies for a PALB2 carrier. On the other hand, if you have a CHEK2, an ATM, or a BARD1 carrier, and you, instead of just taking what the calculation would be from an average odds ratio, and instead you incorporated a polygenic risk score, what you would find is that a substantial proportion, 30, 50, 65% of individuals without a family history, and even a meaningful proportion of those with a family history, are in fact not at a 20% lifetime risk, which is a real problem. Now, the best way to look at things from the clinical perspective is actually by doing calibration of these risk models, which is you look at what's the observed ratio versus what's the expected. So in other words, you have a prospective follow-up of a population, you calculate their baseline absolute risk according to the model, and then you see whether or not the actual risk in the population follows that. What we can see here is that, for instance, for two well-known empiric risk prediction models, the IVIS model and the Bodacina model, which is also called CAN-RISK, as a matter of fact, the observed to expected ratios track reasonably closely, although not perfectly. And therefore, these are considered to be well-calibrated models. If you say that someone has, if you take a group of women who have an 18% risk over the next 10 years, if you followed 100 of those women, you would expect approximately 18 of them to get cancer. Now, what that means for an individual, I think, is a complicated intellectual exercise, but at least from the standpoint of evaluating how things go from the population standpoint, it works. Another way you can evaluate absolute risk models is something called net reclassification index or net benefit index, which is, you take an intervention, let's say MRI at 20%. If you don't incorporate the marker, what proportion of individuals are below that risk level and what proportion are above. And then after you incorporate the model, how many of them switch? In other words, how many of the people that you thought were lower than 20% are actually above it, and vice versa. And this reclassification tells you to some extent the impact of an additional marker on the absolute risk model. But it's important to note that reclassification is not a priori correct. It's possible that you can incorrectly reclassify somebody, so you have to combine this idea of reclassification measurement with a calibration assessment to see whether or not the O to E ratio improves. Now, people are trying to combine polygenic risk with a number of different empiric risk models to try to improve prediction, this so-called integrated risk prediction, and it's been done with essentially all of them. The one that perhaps is a little bit furthest along is the CAN-RISK model, which is based upon the Cambridge-Bodacina model, but the others have been on as well. There's some important things that you have to take into account when you do that, which is that an absolute risk model includes non-genetic and genetic factors like family history, and then you're incorporating the PRS. And this all assumes that all of these factors are independent. But remember, as I showed you earlier, the PRS is part of the genetic component. So you have to adjust that to avoid so-called double counting. Now, also, unfortunately, the genetic component includes the PRS, as I showed you earlier. So you have to adjust both genetic and PRS to avoid overestimating risk. Now, when you put all these things together, though, you come up with some very important data. So these are two evaluations, if you will, of a young woman with a CHEK2 alteration. On the left, she doesn't have a family history. On the right, she does have a family history. The blue vertical line is the population risk in the general population, and the red line is the average risk that you would estimate. All you did was just incorporate the presence of a pathogenic variant multiplied times the baseline incidence in the population, right? So that would guess that she had a lifetime breast cancer risk somewhere around 20-25%. Now, the problem is that if you start incorporating all these other things like risk factors, mammographic density, polygenic risk score, and if you have a multifactorial model, you wind up with this blue curve down at the bottom. So in other words, this woman could have a risk that falls anywhere if she doesn't have a family history between 0 and 45%. And if she does have a family history, anywhere between 5 and 70%. And you don't know for that one woman exactly where she falls. And interestingly, there's a meaningful chance that she actually is at less than population risk, particularly if she doesn't have a family history. And there is an even greater chance that she's less than the 20% risk that we use for instance, MRI surveillance. So the incorporation of polygenic risk score and other factors into risk prediction can have, particularly for moderate penetrance carriers, a really meaningful or potentially meaningful impact on not only their risk estimate, but also what their clinical intervention should be. So I'm going to summarize this by saying that polygenic risk scores are strongly associated with risk, although there's a lot of overlap. Scores that have large numbers of SNPs have reasonably high discriminatory accuracy, but remember, a lot of breast cancer occurs in people who have low to intermediate scores, especially if they're using fewer SNPs. There's a potential for benefit in a number of applications, but individual absolute risk prediction is based on a lot of assumptions. And unfortunately, the calibration of these estimates appears to be pretty good, but kind of remains to be clearly defined, especially in non-European populations. And so I'll leave you with a thought from a well-known statistician by the name of Julie Fox, who said that all models are wrong, but some of them are useful. And I think that's where we are with polygenic risk estimates right now. And it is not a simple task to incorporate this into risk estimates, but mathematically it makes sense if one just adjusts well for all the variables. So thank you very much for all your attention, and if there are some questions, I'd be happy to try to answer them.
Muchísimas gracias, doctor Robson, por su excelente presentación y sobre todo por aclararnos las enormes dudas que nos lleva el estudio poligénico, sobre todo en la población de riesgo moderado. Por lo que entendí, en aquellas pacientes que tienen alto riesgo, el score poligénico no agrega demasiado o no agrega nada, mientras que en el riesgo intermedio podría brindarnos alguna información. Y le quería preguntar, en la práctica, ¿usted cuándo los utiliza?
So I think that the polygenic risk scores are reported by some of the laboratories, particularly in the setting of negative testing for the rare variants. And I think the work that has been done has suggested that the models that incorporate polygenic risk are pretty well calibrated, in terms of the observed to expected ratios. We have trouble accepting that sometimes for people that are up the upper or lower levels of risk. And I think it's a conceptual problem. When somebody has a genetic test result that shows a mutation in BRCA or some other gene, we feel comfortable thinking about that as a diagnosis and treating it as if it is a diagnosis. Whereas when somebody has this very kind of nebulous genetic background that's being defined through polygenic risk, somehow we have more trouble accepting the number that gets attached to that. But very clearly, there are people who are at higher levels of risk in the population who don't have rare variants. And at least part of that has to be due to this genetic background. So I think that we should accept the risk that's provided this way just as much as we accept the risk that's provided by other genetic testing, but it has the same limitations in that it is just a probability, not a definition. And so once we get used to that, I think it'll be helpful, but it's just a tool.
Muchísimas gracias. Muy claro. Muchas gracias, Dr. Robson.
Thank you very much. Ernesto, Dr. Robson. Okay, we'll continue with the last presentation.
Es la conferencia sobre manejo quirúrgico de la axila después de la terapia neoadyuvante. La doctora Yugi Bui, que es jefa de la División de Cirugía de Mama y Melanoma de Mayo Clinic, y el moderador va a ser el doctor Fabrizio Brenelli.
Thank you all very much. It's a real pleasure to be here today and to be a part of this amazing conference. And I believe I am the last speaker of this session. I'm going to load up the slides. Here we go.
Yes.
There we go. Wonderful. So switching topics from what we were just talking about in genetic risk, I'm going to talk about surgical management of patients that have been treated with neoadjuvant chemotherapy, and I'm going to specifically focus on the management of the axilla. And these are my disclosures, none of which are relevant to what I'm going to discuss today. So as we focus in on neoadjuvant chemotherapy, I think this audience indeed really doesn't need much reminding about the multiple advantages of treating the appropriate patients with chemotherapy in the neoadjuvant setting. We've known for many years that it helps decrease the extent of the disease in the breast and increases rates of breast conservation. I'm going to focus today on its role in decreasing the likelihood of nodal positivity and allowing us to de-escalate or personalize our management of the axilla surgically. And obviously the most important thing from a neoadjuvant chemotherapy approach is the ability to assess the response of the tumor to chemotherapy and provide that important prognostic information, which can be used to adjust adjuvant therapies. And part of this obviously involves pathologic assessment of the breast and the lymph nodes. So as we talk about nodal surgery or axillary surgery, the real question we have to ask ourselves is why have we always been performing nodal surgery, and why and when should we continue to be performing nodal surgery? So in essence, axillary surgery really is a staging procedure. The information that we identify from the lymph nodes is used to guide adjuvant systemic therapy and often to guide adjuvant radiation therapy, both in whether it's indicated and which fields need to be radiated. From a surgical standpoint, we believe that it provides an advantage from resection of disease and rendering the patient no evidence of disease and providing some long-term regional control. I think we can say that many studies over the last decades have shown that axillary surgery in and of itself does not necessarily lead to an improved survival. And the question increasingly becomes, is it important to know the number of positive lymph nodes, or is it enough just to know whether the lymph nodes are negative or positive? So first, I'm going to talk on the most easy aspect of this topic, which is those patients that present with clinically node-negative disease at presentation, and based on their tumor characteristics or the extent of the disease in the breast alone, are elected to proceed with neoadjuvant chemotherapy, but have node-negative disease at presentation. And there have been many studies looking at this patient population and have really shown that the axilla can be appropriately staged after completion of neoadjuvant chemotherapy with sentinel lymph node surgery, in that it's feasible and it's accurate. The false negative rate is relatively similar to what we see in the upfront surgery setting. And one of the advantages is that you have a lower rate of nodal positivity and you have fewer axillary dissections, and there is no increased risk of local regional failure. What we've seen over the last decade or so, and this is data from the I-SPY 2 clinical trial, which is a clinical trial of novel neoadjuvant chemotherapy in the US. And I'm going to present several slides looking at kind of the surgical trends of management in the patients treated on that trial. And you can see here for patients with clinically node-negative disease at presentation, the use of sentinel lymph node surgery alone, shown in the blue line, has been increasing over the last decade. Use of axillary dissection has been decreasing. Interestingly, in those that have sentinel nodes that are positive in this setting and proceed to axillary dissection, still about 33% have additional positive nodes on axillary lymph node dissection. When we look at the experience from MD Anderson on patients that were clinically node negative, that underwent sentinel lymph node surgery after neoadjuvant chemotherapy and were found to be pathologically node positive by sentinel lymph node surgery. This was about 12% of these patients. And of that 12%, 63% went on for completion axillary lymph node dissection, with about 26% of those having additional positive nodes at axillary lymph node dissection. So again, here we are seeing, and this will be a recurring theme, that when you have positive nodes after neoadjuvant chemotherapy, there is still a significant risk of additional positive nodes. And we need to remember that this is, by definition, chemotherapy-resistant disease in this setting. So in terms of patients that have clinically node-negative disease that are treated with neoadjuvant chemotherapy, after neoadjuvant chemotherapy, the optimal management to stage the axillary lymph nodes is sentinel lymph node surgery. If the sentinel lymph node is negative, no further axillary surgery is required. If the sentinel lymph node is positive, I would say that the current standard is still a completion axillary lymph node dissection. However, interestingly, this is evolving despite the lack of any level 1 data. So now to the more controversial discussion, which is those patients that present with clinically node-positive disease. Many patients that have node-positive disease at presentation are often considered for neoadjuvant chemotherapy, especially those with HER2-positive or triple-negative breast cancer. So I want to pause just for a second and discuss what does node-positive disease mean and what is our clinical nodal staging. So clinically node-negative is obviously no lymph node metastasis by imaging or clinical exam. But clinical node-positive, it's important to differentiate what clinical N1 is compared to clinical N2. So for clinical N2 disease, you have to have clinically fixed or matted lymph nodes or involvement of the internal memory lymph nodes. For N1, it's any disease in the ipsilateral level 1 or 2 axillary nodes without having fixed or matted nodes. And this is very important as increasingly we are identifying clinical N1 disease by imaging. And when ultrasound or MRI shows 4 or 5 or even 9 abnormal nodes, in the absence of fixed or matted nodes, this is still staged as clinical N1 disease. And I mention this because most of the trials that we have done have been limited to clinical N1 disease and have excluded those patients with fixed or matted lymph nodes, but have not excluded patients based on the extent of nodal disease on ultrasound or MRI alone. One slide, simple slide here, just to say that imaging cannot replace axillary surgery after neoadjuvant chemotherapy in this patient population that presents with node-positive disease prior to chemotherapy. The sensitivity of ultrasound, MRI, and even PET-CT is relatively low, and so surgical staging is still recommended in this patient population. There have been multiple trials, and I'm not going to go into the details of each of these trials because they were reported now almost over 10 years ago, but the Sentina trial from Europe, the 1071 trial from America, and the SNFNAC trial from Canada all looked at patients with clinical N1 disease treated with neoadjuvant chemotherapy. Patients underwent sentinel lymph node surgery and completion axillary lymph node dissection, with the primary endpoint being the false negative rate. And what you can see across these trials is that the false negative rate ranged from 8 to 14%. We learned a lot from these trials in terms of methods to try to decrease the false negative rate. And these trials have really led to the incorporation of sentinel lymph node surgery in this setting. So what have been the methods that we have learned from across these studies that can help us decrease the false negative rate? And I really view this as being a toolbox of options for surgeons and their institutions to use to try to minimize the false negative rate. Several of the studies showed that the false negative rate was lower with the use of dual tracers. So many will use a radioactive colloid along with a blue dye. Other options also available. The number of lymph nodes resected influences the false negative rate. So you should ideally resect at least 2 or ideally more than 2 sentinel lymph nodes. And this occurs in the vast majority of patients on these trials. This is the same as what we've seen in the upfront surgery setting. The more sentinel nodes you remove, the lower the false negative rate. If a single sentinel node has the highest false negative rate. Use of immunohistochemistry on sentinel lymph nodes is useful to help identify small volume disease and further drive down the false negative rate. And then there's been a lot of work looking at marking the index biopsy-proven positive node, which we presume is the most abnormal appearing node in the axilla. That's the one that is targeted for the percutaneous biopsy, leaving some kind of marker, often a clip, sometimes a tattoo, in that positive node when it is initially biopsied prior to chemotherapy. And then at surgery, ensuring that you're resecting that index node, the one that was the most abnormal at presentation, as one of the nodes that is removed at axillary surgery after chemotherapy. A group from the Netherlands coined the MARI procedure, which is just resection of that clip node. More commonly, people are performing what has been coined targeted axillary lymph node dissection, which is the standard sentinel lymph node surgery, encouraged to be with dual tracer, along with resection of the clip node, and that has some of the lowest false negative rates we've seen in sentinel lymph node publications to date. So as I said, these 3 trials, along with the development of targeted axillary dissection, has really led to a relatively rapid adoption of sentinel lymph node surgery in patients that present with clinical N1 disease, have a good response to neoadjuvant chemotherapy, and then proceed to the operating room for axillary staging with sentinel lymph node surgery. The goal really here is to identify those patients that have had the greatest response to chemotherapy, most likely to have negative sentinel nodes, so that those patients that have negative sentinel nodes can forego axial lymph node dissection. And I want to focus on a couple of key points of what I just said. And one of those is having a good response to neoadjuvant chemotherapy. This is not a great tool for those patients that have progression in the breast or in the lymph nodes during chemotherapy. This is to identify those patients we expect to be node negative. And so sentinel lymph node surgery is a reasonable staging method to identify those patients that have had a good response. It allows us to adjust our axillary surgery based on response to chemotherapy, same as we do in the breast, where we can de-escalate from mastectomy to breast conservation. And we know that the rates of nodal PCR are particularly high, predominantly in triple negative and HER2 positive disease. So going back to the I-SPY 2 trial now, looking at the cohort of patients that were clinically node positive at presentation, you can see a striking shift in the management of these patients. The red line shows the use of sentinel of axillary lymph node dissection as the dominant staging method, and you can see this decreased from about 70% in 2011 down to about 30% in 2021. The blue line shows the concomitant increase in the use of sentinel lymph node surgery for staging of the axillary nodes in these patients. Important to note, of those patients that were sentinel lymph node positive that went on to an axillary lymph node dissection, 60% had additional positive nodes. So again, if the sentinel node is positive, significant residual nodal burden in those patients. So how about the outcomes? What about the long-term outcomes of patients that are treated with sentinel lymph node surgery? This is a large cohort study from Europe and from Milan, showing almost 700 patients with clinical N0, N1, and N2 treated with neoadjuvant chemotherapy who became clinically node negative after neoadjuvant chemotherapy and went on to sentinel lymph node surgery. And importantly, in this cohort, no axillary lymph node dissection was performed in those patients that were negative on sentinel lymph node surgery. And you can see here the axillary recurrence rates in the clinically node positive group of 1.6% with a negative sentinel node, 2% in those with a positive sentinel node that went on to an axillary lymph node dissection. Overall axillary recurrence rates were low at 1.8% in the node positive, 1.5% in the clinically node negative at presentation, really showing that this use of sentinel lymph node surgery after neoadjuvant chemotherapy to identify those with negative sentinel nodes is appropriate. When we look at this large cohort study from the OPBC-04 U-breast cohort, taking in centers across Europe, South America, and America, you can, this was patients that have presented with node positive disease, underwent surgery with either sentinel lymph node surgery or targeted axillary dissection, and were found to have a nodal pathologic complete response. So eradication of nodal disease. And what you can see here is axillary recurrence rate at 5 years was 1%. And importantly, there was no difference between axillary recurrence between those patients treated with sentinel lymph node surgery or targeted axillary dissection. So the important thing is just an appropriate evaluation of the axilla with low local recurrence at 5 years. So having accepted that sentinel lymph node surgery is an appropriate staging procedure after neoadjuvant chemotherapy in those patients presenting with clinically node positive disease, and having accepted that those that convert to node negative, it is safe to forego axillary lymph node dissection, the next echelon and the next boundary that we really need to evaluate is the management of those patients that have a positive sentinel node after neoadjuvant chemotherapy. So I'm going to take the smallest group first, which is the group of patients with isolated tumor cells. And this group of patients with isolated tumor cells, the retrospective studies, and as well as 1071 showed us the likelihood of additional positive nodes is about 37%, so pretty high. So how should we manage patients with isolated tumor cells? Well, this is from the similar OPBC cohort. They looked at 583 patients that had residual isolated tumor cells in the sentinel node after neoadjuvant chemotherapy. Majority of these patients were node positive at diagnosis, and the mean number of sentinel nodes that had isolated tumor cells was 1.2. In this cohort, 31% of patients went on to completion axillary dissection, and 69% of patients did not have axillary dissection, showing that surgeons and patients are already self-selecting in this group. But among the 31% of patients that had a completion dissection, 30% had additional positive nodes at axillary lymph node dissection, which obviously would have been left behind if completion dissection was not performed. When we look at the curves showing axillary recurrence, we can see no significant difference in axillary recurrence, with 5-year rates of any axillary recurrence of around about 4% in both groups, and isolated axillary recurrence of around about 1.5% in both groups. When we look at invasive recurrence, similarly, no difference in the 5-year rate of any invasive recurrence. Not surprisingly, the third of patients that underwent axillary lymph node dissections were tended to be those that had higher nodal burden at presentation, isolated tumor cells detected on frozen section, lymphovascular invasion in the primary tumor, and most of these patients obviously underwent adjuvant radiation. So moving on to the more common situation, which is what about those patients that have sentinel lymph node micrometastatic or macrometastatic disease after completion of neoadjuvant chemotherapy? Here we know there's even a higher likelihood of additional nodal disease on axillary dissection of around about 60%. What is the optimal way to manage these patients? Well, this becomes one of the main debates right now. Do these patients need axillary lymph node dissection, which I would say is still the current standard of care? It allows us to remove the additional positive nodes and identify the number of involved nodes. It allows us to identify the residual nodal burden, but we know that axillary dissection has a higher lymphedema rate. It provides good local control, but as I mentioned earlier, we don't really see a survival advantage. Could axillary dissection be replaced by axillary radiation, which we know is good at controlling low volume disease? But if we radiate the axilla, we don't really know what the residual nodal burden was. Will it provide us good local control? We know it does have a lower lymphedema rate. So what has been happening in practice? I come back here to the I-SPY 2 study, and now we're looking at only those patients that had pathologically positive nodes at surgery after neoadjuvant chemotherapy. And the red line again shows that decrease in the use of axillary lymph node dissection from about 70% to about 29% after in 2021, and an increase in the use of sentinel lymph node surgery in this patient population. And when you look at this patient population, you can see that those that underwent sentinel lymph node surgery only, i.e. those that had omission of axillary dissection in the setting of positive nodes after chemotherapy, were more likely to have had smaller tumors at presentation, more likely to have lower extent of disease in the breast, more likely to have been clinically node negative at presentation, and have a lower number of nodes removed. And these were the ones where we were more comfortable in omitting axillary dissection. And when we look at the outcomes, we can see no significant difference in the axillary recurrence rate between the use of sentinel lymph nodes alone versus axillary dissection. In fact, numerically, axillary dissection had a 3.6% axillary recurrence rate, sentinel lymph node only 5.2%. Local regional recurrence does separate a little bit more, but interestingly, the local regional recurrence was higher in the group with axillary lymph node dissection, reflecting that these are the patients that have higher burden disease, poorer response to neoadjuvant chemotherapy, i.e. more aggressive tumor biology, and it's not necessarily a feature of the surgery. And similarly, when we look at distant recurrence-free survival and event-free survival, we see no significant difference between these two, again, with those patients that were selected for axillary lymph node dissection having poorer outcomes due to having poorer tumor biology and more extensive disease, despite having had more appropriate axillary management with axillary lymph node dissection. So the extent of residual disease and the tumor biology is what drives oncological outcomes, but the type of axillary surgery does not necessarily impact the oncological outcomes. So this is encouraging data, but this is retrospective data from highly selected patients. When we look at this important publication out of the group from Turkey, looking at almost 1,000 patients with node-positive disease treated with neoadjuvant chemotherapy that were clinically node-negative after chemotherapy, treated with targeted axillary dissection or sentinel lymph node surgery. Now, important in this cohort, none of them had an axillary lymph node dissection, even if they had positive sentinel nodes, and all of them had regional nodal radiation. And you see very low rates of recurrence, both in targeted axillary dissection versus sentinel lymph node surgery, shown on the left-hand side of the table, and even comparing YP node negative disease to YP node positive disease. So low recurrence rates with the omission of axillary lymph node dissection, albeit with relatively short follow-up of just 39 months in this study. So how about micrometastasis? There has also been a very large cohort study from the OPBC group looking at over 1,500 patients with residual micrometastatic disease after neoadjuvant chemotherapy. This data was presented most recently at the Society of Surgical Oncology meeting and is currently being under review for publication. 50% of this patients with micrometastasis underwent axillary dissection. 50% did not have axillary dissection. Median follow-up, and it's important to note this at this time, is very short at just 3 years. 50% having luminal breast cancer, about a third HER2 positive, and 20% triple negative. Among those 50% that had axillary dissection, again, we see 30% had additional positive nodes on axillary lymph node dissection. And when we look at the overall cumulative incidence of 5-year rate of recurrence here, we see this is very relatively similar between the axillary dissection and the no axillary dissection when we take all comers. However, it's very important to look at this table, which shows the factors associated with axillary recurrence. And strikingly, we see a much higher risk of axillary recurrence in patients with triple-negative breast cancer, a higher risk of axillary recurrence with omission of nodal radiation, and a higher risk of axillary recurrence with larger tumor burden at presentation. When we look at the triple-negative breast cancer patients, we see a significant difference in axillary recurrence rates between those treated with axillary lymph node dissections and those that did not have an axillary lymph node dissection, with a 9% risk of axillary failure in patients with omission of axillary dissection in the setting of triple-negative breast cancer with micrometastatic disease in the lymph nodes. So this is really our first big red flag that maybe de-escalation and omission of axillary lymph node dissection with chemotherapy-resistant disease in the axilla may not be optimal. And so more data is really needed in this area. The Alliance 11202 is one of the 2 big trials nationally that has been looking at this question. Alliance 11202 is randomized patients with sentinel lymph node positive disease to either axillary dissection and nodal radiation versus omission of axillary dissection with definitive axillary radiation and nodal radiation. It has completed accrual, and we await the follow-up of the patients on this trial. Similarly, we await data from the Taxus trial from Europe. There was some early data about the patients enrolled in the 11202 trial that I was able to present at San Antonio last December and is being submitted for publication in the next month. Looking at the patients enrolled in 11202, we enrolled over 1,700 patients with pathologically node-positive disease by sentinel lymph node surgery or TAD. Randomization was to axillary dissection or omission of axillary dissection. When we look at the tumor biology of patients enrolled in this study, the vast majority, 69%, had hormone receptor positive HER2 negative disease, 18.6% HER2 positive disease, and 12.5% triple negative disease. And this, I think, is reflective of the fact that this patients that could be registered and randomized were patients with node positive disease. And it's interesting when you look at the B51 trial, which was our sister trial, looking at patients that were pathologically node negative, asking the question of radiation versus no radiation, only 21% of the patients in that trial had hormone receptor positive HER2 negative disease. So this really reflects the lower nodal response rates in hormone receptor positive HER2 negative disease. When we look at the number of sentinel lymph nodes examined, the majority had 3 or 4 sentinel nodes examined, most of the range, most commonly being between 2 and 5. And the number of sentinel lymph nodes positive, and I found this very striking, 55% of patients had a single positive sentinel node. So the patients that we as surgeons were selecting to enroll in this clinical trial that randomized to potentially axillary dissection versus omission of axillary dissection, we were selecting those patients with low volume disease in the axilla, with 55% having a single positive node. 83% of patients had micrometastasis and 16% had 83% had macrometastasis, 16% had micrometastasis. When we look at the group that were randomized to axillary lymph node dissection, 841 patients, 46% had additional positive nodes on axillary lymph node dissection. Look at the inverse of that, 54% did not have additional positive nodes, but 46% did have additional positive nodes. So almost half of the patients, but despite the fact they had low nodal burden, had additional positive nodes on axillary dissection. We would anticipate that a similar proportion in those with omission of axillary dissection also had additional positive nodes left behind. There's a significant difference in the likelihood of additional positive nodes between macrometastatic disease versus micrometastatic disease. And there was a trend towards a higher rate of additional positive nodes in the hormone receptor positive HER2 negative group. When we look at the influence of the number of positive sentinel nodes, we see this very nice stepwise increase in the likelihood of additional positive nodes on axillary dissection. And so you can see here with a single positive node, 33% had additional nodes on dissection. With 2 positive nodes, 53%. And then with 3 or more positive sentinel nodes, 71%, 84% high rates of additional positive nodes on axillary dissection. On multivariable analysis, the key factors associated with additional positive nodes was the number of positive sentinel nodes and the number of sentinel nodes examined. And importantly, proceeding with axillary lymph node dissection actually changed the pathologic stage of a quarter of the patients, 25% upstaged with the information identified on axillary lymph node dissection. So to summarize and to wrap us up for this amazing conference, for clinically node negative and clinically node positive disease treated with neoadjuvant chemotherapy that have a good response to neoadjuvant chemotherapy, sentinel lymph node surgery is the ideal staging procedure after completion of neoadjuvant chemotherapy. Ideally, we should be using dual tracer and where possible, identifying the clip node in those patients that were node positive at presentation. When patients are found to be pathologically node negative by sentinel lymph node surgery, no further axillary surgery is required. In the setting of isolated tumor cells, axillary dissection, I would argue, is still the dominant standard of care. There's increasing interest in no axillary dissection in these patients, but we do need to note that there is additional positive nodes in about 30%. And while the ICARO study showed short-term retrospective data indicating omission of axillary dissection was reasonable, we still need longer-term follow-up. And for patients with micrometastatic and macrometastatic disease, we await the results from the A11202 and the Texas trial. I would say the standard of care is still axillary dissection. Short-term retrospective data indicate maybe omission can be considered in selected low-risk patients with HER2 positive or hormone receptor positive HER2 negative disease. I think we need to be very cautious in triple negative disease. And overall, I would still say the standard is axillary dissection, and we need the randomized controlled trials to change guidelines and change the path for our patients moving forward. Thank you for your attention. I'd be delighted to take questions.
Muchas gracias, doctora Gugui. Le damos paso al doctor Fabrizio Venenelli para hacer las preguntas. Estás muteado.
Okay. Thank you very much, Gabri, Faranti, Karina, for the invitation. This amazing conference and this amazing lecture by Dr. Judy. I have a lot of questions, but I can make only one question. It's a very practical question. For example, a patient that you find in the frozen section, she is negative at sentinel node biopsy after neoadjuvant chemotherapy in a previous N1 patient. Then on the final pathology, she's positive. What do you do? Do you discuss in multidisciplinary team for radiotherapy, or you always take back the patient for the OR for doing axillary dissection?
Fabricio, thank you for that excellent question. And you went straight to my heart because you know that at Mayo we use a lot of frozen section. And so with frozen section positive, it's a much easier decision when it comes to a patient, you know, often with our practice, a couple of days, but in many practices, a week or two after surgery, already in their healing from their surgery. And the question becomes, do you take them back for a second operation? In that setting, I would say my textbook answer, my answer when I'm on the podium, is an axillary lymph node dissection. I would say in my clinical practice, we all know that it varies a little bit. I have a comprehensive discussion with the patient. It very much varies a little bit on their preferences and their concerns. Also look at the extent of the positivity. So how big is the metastasis? How many nodes are positive? How much residual disease was there in the breast? How young is the patient? And, you know, I think increasingly in my practice with micromets, I am becoming a little bit more comfortable with axillary dissection, despite the fact we don't have the data. I think if I have 2 or more positive nodes, I'm much more leaning towards an axillary lymph node dissection. Single positive node, it's very much leaning on the multidisciplinary discussion and shared decision making. But I do worry that even personally in my practice, we're de-escalating too quickly without the data. And I worry that if we do that too quickly and the data comes out and shows us that axillary dissection is inferior, that pendulum may be swinging too fast for us.
Perfect. Thank you very much, Judy.
Thank you.
Thank you. Muchísimas gracias. Vamos a continuar con la presentación del curso para dar cierre.
Gracias. Sí, gracias a todos. Agradecemos a todos. Estamos cumpliendo con el tiempo, Gabriel, siendo 1:10, estamos casi ya terminando. Agradecemos las excelentes conferencistas y las charlas que pudimos presenciar. Queremos recordar el tema de que pueden acá sacar el QR o ver en el chat para que le mandemos el libro. Este libro es el Manejo del Cáncer de Mama, que ya nos presentó el doctor Farante, el Instituto Europeo de Oncología, totalmente gratuito, así que el que lo quiera lo puede solicitar sin ningún tipo de cargo. Realmente creo que es una oportunidad excelente que nos da el Instituto Europeo de Oncología para mostrarnos cómo trabajan y para poder seguir avanzando en nuestros conocimientos. Así que, Gabriel, muchas gracias. Sé el esfuerzo que haces como para que esto llegue, se traduzca al español y lo podamos tener tanto en inglés o en español. Cari, continuamos ya terminando. Los invitamos. No sé, no sé, Gabriel, si querés vos cerrar con algo en particular. Cerramos. No, estás muteado.
Estás muteado, Gabriel.
Decía que agradecer a todos los participantes y los esperamos a todos el año próximo. Muchas gracias por participar.
Exactamente. Ya
Muchas
sé que vas a
gracias.
empezar a trabajar para todo el programa científico del próximo año. Así que, exactamente. Y bueno, y nosotros nos despedimos también. Les volvemos a ofrecer todas las sorpresas y los cursos. Seguramente va a haber también algo que no pusimos acá, pero va a haber algunos cursos online de CLIM durante este año. Los esperamos el año que viene en Miami, del 27 al 29 de marzo. La modalidad presencial, realmente una experiencia que creemos que es muy satisfactoria. ¿Querés, Cari, mostrar un poco lo que van a vivir en el curso?
Sí, van a tener la posibilidad de compartir con colegas de toda Latinoamérica, tal como fue la edición de marzo del 2025, en donde participaron expertos de diferentes países de Latinoamérica. Tuvieron la oportunidad de realizar biopsias bajo ecografía, bajo estereotaxia, tomosíntesis, bueno, participar con la posibilidad de trabajar casos clínicos complejos con monitores de graduación médica, tanto mamografía, tomosíntesis, resonancia y mamografía contrastada. Así que es una gran oportunidad y crear redes en toda Latinoamérica. Los esperamos entonces para marzo del 2026 y también quiero agradecer al doctor Gabriel Farante por la posibilidad de confiar nuevamente en nosotros, en la comunidad latinoamericana de imagenólogos mamarios, para poder acompañar y presentar estas conferencias que traen material exclusivo, cosas que van a cambiar realmente hoy. Se trataron temas que probablemente sean cambios de paradigma en la que es la cirugía, en el manejo de las pacientes. Así que muy agradecidos por esta oportunidad de mantenernos actualizados con expertos de los primeros lugares del mundo en oncología. Así que muchísimas gracias, Gabriel, por esta posibilidad. También agradecer a todo el equipo de Tecnoimagen, que como siempre nos da todo el soporte técnico para poder acompañar y brindar a toda esta comunidad de médicos que están tan ávidos de información de alto nivel como la que fue hoy en día compartido con todos nosotros. Así que muchísimas gracias a todos ustedes por el compromiso y estar aquí hoy presentes.
Exactamente, gracias a todos, gracias Gabriel, gracias Cari también, como siempre, por acompañar y por poder llevar a cabo toda la moderación de todo el curso. Realmente muy cómodos y gracias a Tecnoimagen. Así que ya siendo la 1:05 dentro de los horarios que teníamos pautados, nos despedimos de todos, agradecemos a todos los que han participado de estas jornadas espectaculares y haber llegado hasta el final. Así que muchísimas gracias. Gracias, el doctor García Gerardi, gracias Ernesto, gracias la doctora Krakowski, Fabricio, Judy, bueno, todos los que estuvieron durante todas las jornadas. Hasta la próxima. Muchas gracias.
Hasta la próxima. Gracias. Chao, chao.
Chao.
Nos vamos con un video y recuerden que el certificado estará dentro de 15 días, lo van a recibir en su correo.
la vida siempre tomamos decisiones. Decisiones que nos acercan al futuro, que nos permiten brindar un mejor cuidado y avanzar con confianza. En Tecnoimagen abrimos las puertas a la innovación, pero con un propósito claro: acercar la tecnología a las personas. Porque cada avance, cada desarrollo, cobra sentido cuando impacta en la vida real de los pacientes. Hoy celebramos 25 años trabajando codo a codo con quienes nos eligen, acompañando a los profesionales de la salud en su crecimiento, compartiendo cada desafío, cada logro, porque sabemos que la tecnología solo es innovación cuando está al servicio de las personas. Gracias por elegirnos para recorrer este camino juntos. Celebramos 25 años de innovación y compromiso con la salud.